This is the moment we all been waiting for. We have the superstar, Dr. Zaghi, with us. And you don't need any
all right,
introductions.
thank you so much.
Just
thank you
take
so
it away
much.
from here.
Amazing, amazing. So great to be here with you guys. This is one of my favorite conferences of the year. I have so many friends in the audience. Who is ready to have a good time? Let's hear some noise. Yeah! Amazing, amazing, amazing. I wish I could have been with you guys here all weekend, but I now have 2 little kids at home, a 6-month-old and a 3.5-year-old. But I have my amazing team here in the front row. You guys can stand up. Stand up to my Breathe team. They were sending me pictures, videos of all your presentations and all the love, and it's so great to be here with you. My name is Dr. Soroush Zaghi. I'm a graduate of Harvard Medical School, UCLA ENT residency, and Stanford Sleep Surgery Fellowship. I'm medical director of the Breathe Institute, and one of the greatest things we love to do is research and education. Who here is excited to get some updates on our latest protocols? Yes. If you would like a copy of the lecture slides, which I would recommend that you grab because we have some new content, new grading scales, pictures and things like that, go ahead and click on the QR code here. I'll put it up again in a few minutes, and then you'll have access to all of the pictures, diagrams, things like that. We do want you guys to use these to help your patients and implement it in your research. If you use any of the content, be sure to credit Dr. Zaghi and the Breathe Institute. All right, very, 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 very good. Can you guys believe it that we are now in year 7 of the Breathe Institute and these protocols? The first presentation I gave on these topics was 7 years ago. Is that incredible or what? Meanwhile, I have been using the same slide over the past 7 years, explaining that half of what you learn will be shown to be either dead wrong or out of date within 5 years. And so the most important thing is to continue learning. And we do that continue learning through research studies as well as study clubs like this one. I love to update all my studies and come to you guys, and the input that you give today will influence the direction of research moving forward. We just had our annual TBI Ambassador Update. Who was online with me at the TBI Ambassador Update? Amazing, amazing. And I'll be summarizing a lot of those key concepts in the next 3 hours. The first concept that I'm going to talk to you guys about is our surgical advancement. If you guys have taken the course from me or studied with me more than 1 or 2 years ago, I want you guys to know that the procedure is now much, much less invasive. We're making very, very small cuts. We're no longer dissecting through the fascia into the genioglossus muscle, and we're getting incredible results. I want to teach you guys about the Kenalog 10 protocol. Who's here has heard about this? Okay, who here has tried it? Okay, impressive? Is it impressive or what? Okay, so we do a lot of different research projects, and some of them just hit. And I'm so excited to share with you guys how we can improve our wound healing process through the application of Kenalog 10. And I'm also going to introduce a new grading scale for how we can evaluate the integration and maturation of wounds. Last year, I introduced the non-ablative laser. Who here has tried it in the last year? Amazing. I want to give a big shout out to Dr. Sophia and Dr. Katz. Lately, yeah, amazing presentation. She videoed it and sent it to me. What's that? Dr. Huffman and Dr. Katz. Sorry about that. I know that you guys didn't get the best results in all of the patients. And so I found like a little trick that it's not only getting the soft palate area, but also the posterior aspect of the soft palate. And I've got the procedure down to like 2 minutes, like once, maybe twice, okay? Minimal pain, like demonstrable changes on CT scans. Excited to share with you guys. And finally, we're going to talk about our research that I introduced last year on lip and buccal ties. So I hope you guys are excited. One more chance to get the link to the downloads. Anyone still need it? And looks like we're good to go. So again, the biggest change from last year is that I am now a father of 2 amazing boys. And one more change. Anyone else know what's changed personally for me in the last year? My airway journey, all right? So I thought, you know, we're all friends here, and I thought I'd give you an inside look on my journey. How does that sound? You guys excited to kind of hear about that? So 7 years ago, I presented you guys this case. His name is Austin. You can see based on his craniofacial features that he has maxillary mandibular deficiency. If you studied with me, you've seen his sleep endoscopy where he's gasping, choking, and ultimately we take him for MMA and he does a lot better. Meanwhile, there are 2 patients in this picture. All right, one of them's Austin, and the second is Dr. Zaghi. Because when I go back and look at my videos from 2017, 2018, my mouth is always wide open. Oh my gosh! I'm supposed to be an expert in sleep breathing and tongue posture and tongue thrust. And here I am, having graduated from Harvard Medical School, having graduated from UCLA ENT residency. And it wasn't until I got to Stanford that I realized that, oh my gosh, I have an open bite and I'm a mouth breather. Imagine that, graduating ENT residency and not knowing that you have these issues. Really a testament to the need for continued learning, the need for interdisciplinary, multidisciplinary approach. So here's what my bite looked like. I think it was like in the 7th grade or something like that. I got hit in the face with a basketball. I developed a deviated septum, couldn't breathe through my nose as well. I thought it was allergies, and then I developed a tongue thrust. My intermolar width here is maybe around 33, 34 millimeters, and we'll talk about how that plays a role in the decision between tongue tie versus tongue space issues in the course today. So, here's my deviated septum. I had sinus issues, and so, I saw what great results my friends and my patients got from, sinus surgery and deviated septum surgery, so I went for it. So almost 2 years ago, I had septorhinoplasty, spreader grafts placed, and sinus surgery, and I was better. And I did some orthodontic treatment in the form of, Crozat and Invisalign, and I did get some dentoalveolar expansion. And I was so proud of myself, and I went to a conference, and Mariana Evans looked at me and said, your bite's not stable, okay? Like what are you kidding yourself, okay? I started to get periodontal root reabsorption, and as soon as I took my retainers out, my bite would shift right away, all right? And so that's a sign that if night to night, you take your retainers out, the next day it's tight, that something's not right. Is it your tongue posture? Is it your tongue space? And in my case, I had a skeletal deficiency of the maxilla, such that my maxilla, which is the roof of the mouth and the floor of the nose, was more narrow than we would like to see. I had some transverse maxillary hypoplasia. And so even though I did an orthodontic treatment, I'm sure you guys can see the extensive periodontal effects of that treatment over the course of 3-4 years of constant stress on the teeth. And then, you're not wearing the retainers during the day, so you're constantly having that push and the pull. And so ultimately, I had many patients doing MARPE. I had contributed to the research on the dome procedure back in 2015, 2016. And, the research has really come a long way. Who here has heard of MARPE? Who here has had the procedure? Anyone? Okay, a couple people in the crowd, okay? And so basically what happens in this approach is that what you're doing is you're actually expanding the maxillary skeletal tissue. And the research has come a long way in that we're not doing the dome procedure, which has a Lefort 1 osteotomy. Rather, we're expanding at the fulcrum of the zygomatic frontal suture. And so you're getting a 3-dimensional expansion of the floor of the nose, the sinuses, the nasal wall. And it's been shown to be a really reliable and effective way of contributing to not only breathing, but also aesthetic results. So I dived in for my journey. Here is how I presented with my open bite. Look at that tongue posture, okay? I got a CBCT machine, I sat in it, and I'm like, oh my gosh. I did some expansion and Crozat and Invisalign and therapy and got my nose breathing up, and I got my tongue up, but still not quite there. There's different ways of expanding the palate, okay? We have, light wire modalities. We have removable appliances, and both of these modalities work, but they're limited to about 2 to 6 millimeters of expansion, and that's what we see in the recent studies, that yes, These appliances do expand on average about 2.4 millimeters plus or minus 1.8, which means that if you have a patient who's 34, 35 millimeters going for a goal of 38, it's an acceptable option. But if you have a patient who's 28 millimeters, less than 32 millimeters, you could do these modalities, but you're going to be limited due to periodontal root resorption and other issues in terms of how far you can go. And so what we are now doing about a year ago was maxillary skeletal expansion with surgical assist. And even since that time, it has become possible to expand people with less and less surgical actually cutting of the mid-palatal suture. And so what I had was the MIND procedure. It involves an amazing appliance from Partners Lab that you get implanted. I had actually 6 mini implants into the maxilla, and we were expanding about 1/6 millimeter per day. Let me give you a little look into my journey.
Big airway energy.
Good morning, let's go.
Yeah.
My honor to take care of you. You're my brother.
Seeing your patients come in and out with teeth from here to here, and I want the same.
Let's do it, let's do it.
Oh yeah, Dr. Koppelson.
Locked and ready to go.
Woo!
All right, amazing. So, I want to show you guys. So I had a bad gag reflex, very thick bone. Even in the OR, it was hard to place this. I want to give you guys a little bit of a look of what my process looks like, okay? So here I am, all right? And I had nasal endotracheal intubation. I'm sharing this with you to make the process a little bit less scary for you and your patients, showing you that I walk the walk because patients with tongue ties don't have only tongue tie issues. They have myofunctional issues and they also have orthodontic issues. And we have to learn and be willing to, approach this from 3 dimensions if we really want to help our patients. So this is me at Miracle Mile Surgery Center, and I got intubated, all right? Is this okay for you guys to see? You guys interested in seeing a little bit of this video? Okay. Numbed me up, okay? Put the palate in, brush my teeth, put the palate expander in, and here's the good stuff, all right? Does the sound up? You turn it on. Yeah. So he makes a cut through the mucogingival junction there, and elevates the lip until we expose the nasal spine. That right there is accessing my nasal floor and my septum, and so he separates the septum from the nasal floor. So that's the nasal septum. We're like right above the maxillary spine. So you separate the septum, you make a mid-palatal split, and there's also a pterygomandibular disjunction. This is him putting the screws in. Much more comfortable when you're asleep than awake. All right. Giving you a sense of what it looks like, the disjunction. It was about, an hour and a half kind of a procedure that they summarized in about 10 minutes. This is fun. My part's easy, you just gotta sit there, huh?
Look at Dr. Zaghi's split already looking beautiful.
They split, and then they test the palate expander, and now you can do it. You can expand an adult. Are you guys convinced? Do you guys need a randomized double-blinded control study to prove to you that you can split adults? All right, this is evidence, guys, okay? And I'm sharing this and I'm describing this because, research and evidence has become weaponized. Have you guys seen it? Have you guys seen that? Yeah. really distasteful people going online saying there's no evidence, there's no evidence. They do all this work, all this research is showing there's no evidence, right? And so I'm sharing this case with you to tell you guys that when something's self-evident like this, right, you don't need a double-blinded, randomized controlled trial to show that it works. You have to use the level of evidence that's appropriate to advance your understanding and your learning, all right? So this is just the first part of my journey. The second part is really the recovery, okay? So afterwards, I was having a little bit of swelling over my cheeks and in my jaws. I'm using an ice pack for my face, 2 or 3 times a day. So it's about the recovery process. So I used an ice pack to help with the swelling. Here's Dr. Koppelson going over my CT scan, and he's, verifying the placement of it, that the TADs are in the right place, and making sure I'm good to go. You wait for a week, and then you start the expansion process. So I'm become a big advocate of ice, okay, for my personal experience, but also after frenuloplasty, all right? So something new that's in the protocols is applying ice to the submental area, and the way that you do that is 15 minutes on, 2 hours off, 15 minutes on, 2 hours off, and we're moving away from giving patients benzocaine and topical anesthetic and tramadol and things like that. Especially with the finer technique, patients are having very little pain, and the ice helps to diminish pain and swelling and can be extremely helpful. Anyone try icing after oral surgery, tongue tie? Finding that it helps, okay? And little to no risk, okay? So 15 minutes on, repeat every 2 hours. The other thing that I found extremely helpful, and this is a laser symposium, is photobiomodulation. So I had 2 modalities. I had the 800 nanometer wavelength, which is a red light wavelength, and the red light works for inflammation, all right? And I had the 1064 nanometer wavelength, which works on the level of fascia. I also experienced shock wave therapy. And so going through this journey taught me things that no textbook, no research article could, okay? Putting yourself through there is like the best way to learn. The second best way to learn is through the journey of your patients. I also want to give a shout out to my friend, Dr. Neil Bulchandani, amazing integrative airway chiropractor. Really taught me a lot about what body work is, like craniosacral, fascia therapy, chiropractic work. This makes a huge difference, because you guys know what the biggest risk of palate expansion is? What's the biggest risk? Asymmetric split. And it doesn't look good. It doesn't look good, right? You have this thing in there, and you got to get through the turns. So you turn, and then it splits asymmetrically. Like one side of the maxilla comes forward, all right? The teeth are off, one's up, one's down. Anyone ever see this? All right? Why does that happen? Why does that happen, right? The body's resisting that movement. So if you integrate the body work, the craniosacral, the chiropractic adjustments, and you go a little bit slower, stop if you're feeling that headache sensation, stop if you're having any pain, go a little bit slower, you're gonna get a really nice, smooth, symmetric result. Any questions or comments on that? You guys agree? Yes, doctor. Rarely. If it's a sensitive patient, this and that, I give them 2 tablets and that's it. Yeah, so we're not finding that we need it. Here is how will the process start, right?
So this is the expansion screw. You want to make sure it's locked in all the way, right? So once you feel like it's locked in all the way, it's always going from upper incisors to lower incisors. That's activating it. So, boom. Did you feel that?
Oh my God. Whoa.
Where'd you feel it?
In my cheeks, like right here.
Yeah.
Just like that.
Yep.
Whoa.
Amazing, huh? You want to do one more?
Do one more?
Let's do one more.
I have craniosacral tomorrow, so I'll be good for it.
Good timing.
Yeah, so it doesn't matter which way?
Doesn't matter. Just you want to make sure that when you're starting, you're not starting too low, right? Because then you have no room to go down. Okay. So you want to make sure that when you're in, you may have to flip it. You can flip it
this way, or?
Sometimes you have to flip it just to get the right angle. Nice.
Oh. Wow.
Feel it?
Oh, I feel it. Oh, right here.
Yeah.
Right here.
A lot of people feel it.
Yeah.
Right here around the zygomatical frontal
I'm
suture.
so glad I got my suture split.
Yeah.
Imagine if you don't, right?
No. So now you're gonna start to figure out if you're doing enough of that. Okay. So you see how this is a blank surface? You see that?
Didn't do enough then. So it's not right.
No. It's fine.
That's how it is?
So every other surface has a marking on it.
Okay.
So let's say that surface is blank.
What I'm trying to demonstrate here is like it works, okay? But these patients experience tightness, right? And the body work, the physical therapy, the stretching, like really helps. Because if you get stuck, it's gonna go asymmetrically. And in Audrey Yoon's paper, it showed that 51% of patients in the prior technique, 51% had asymmetric expansion more than 1 to 2 millimeters. And that's a lot. That's a lot. So what are we missing? We're missing that integrative work. The other thing is if they have a lateral tongue thrust, okay, and they keep their tongue on one side. Have you guys seen those patients? Okay. Oh, asymmetric split. Asymmetry. It's gonna grow like that. All right? So what do you do first? Do you do tongue tie first or the tongue space first? All right? There's different considerations. If you do the tongue tie first, you're gonna optimize the expansion, the fascia, the tongue up. If you do the tongue space first, well then the myofunctional and the fascia and all that's easier. So, I think in prior years I said, look at tongue space, look at tongue space, look at tongue space, and I'm gonna qualify that in this seminar, that most patients who have tongue tie are gonna be narrow, okay? It's gonna be unusual to find a tongue tie patient who's wider than 34, 35 millimeters because they have the tongue tie, the palate hasn't expanded. If you're less than 32 millimeters of palate width, if you're like 28, and the tongue tie is like not so bad, okay? It's like maybe like a compensating form of tongue tie, but not like a severe grade 3, grade 4, really bad tongue tie, expand first, okay? If you have a very severe, okay, like grade 3, grade 4, thick, restricted tongue tie to the tip, you might consider releasing first and expanding second, okay? With the caveat that after you release it, they may have problems such as biting the edges of their tongue. And they probably will have that complication, okay? But that's okay, because it's gonna motivate them to go through. They're gonna understand the importance of therapy to expand and get their tongue in the right place. Meanwhile, if the tongue's in the wrong place, it's gonna limit your growth. Another option is to expand, get that space, and then do the tongue tie procedure in the middle of the retention phase, which means that you do all the spacing, and then when you have the diastema, you do it there. That's like my favorite time to time it. Any questions about optimal timing of release, tongue space versus tongue tie? Is this helpful for you guys, getting these inner looks? Yes. It's very important to have your tongue up during that process. During the retention phase and even some of the expansion phase, it's very important for the sense of ease around your head and the stability, because it's the swallow that's regulating it. So you expand, okay? And then it's your swallow and your craniosacral rhythm that's moving everything into place. And if you have an abnormal swallow, you're not gonna get the best results. I was doing body work probably 2 or 3 times a week, and that was helping. But just getting the tongue in there, once I got to a sufficient width, and I would swallow, the swallow would equalize out that pressure and help me to feel better. Does that make sense? Is it helpful insights? Okay. Other questions? So, you expand enough so the tongue space is adequate, do the tongue tie release, maybe expand a little more, maybe retain. Yes? Yeah, I'm gonna show more specific on all these things in the second half, so around 11 o'clock or so, 10:30, 11 o'clock, I'll show you the pictures and the measurements and things like that. Just giving you, I'm gonna repeat things multiple times if you guys have studied with me. I introduce the concept, kind of plant it there, introduce it again, and then hit you with it at the end. Sound good? You guys on board? All right, really, really, really good, okay? So here's my palate expander, amazing, okay? But another thing that needs to be mentioned is the psychological effects of a diastema, all right? It's hard, all right? And it's a concern that patients have. It's like, what about the diastema, all right? And this is 4.2, I went up to, 7 millimeters, okay? And you go out to weddings and your kid's birthday party, and people look at you like you're off the wall, like you're crazy, like what happened to you, okay? And it's your real friends that'll point it out, right? It's your real friends. I have a friend from high school who's like, Soroush, what did you do? What's wrong with your teeth? Oh, You know what I love you. Thank you for caring about me. Thank you for being such a good friend, right? It's the ones that are like, oh, so well, what's new? What's going on in life? Anything different with you? These are people who are not that close to you, right? So it's important to recognize this. There's two ways that we're going about this, okay? One is that you can expand and do Invisalign at the same time to correct, all right? There's pros and cons to that. When you have the Invisalign retainer, you're blocking some of the craniosacral symmetry, like effects, because as your body changes, your posture changes, and you lose that. You lose that mobility to reset everything else in your body. But you can, do that. You can expand and reset, and there's some research that's being done into that. And the other is that you own it, right? That you own it, that you tell everyone, hey, airway is important. Here's an opportunity for me to tell you guys why this is important. And I wish that I had addressed this when I was a child, when I was an infant. It's a lot easier. Public awareness, public service announcement, okay? So if you're gonna go through this, go with that kind of attitude that, hey, this is important. This is my case. This is what I did. Breathing is valuable. Breathing is important. My sinuses are better. My posture is better. And that's really how you're going to get the word out there. That's how you're going to beat these New York Times articles and these ASHA leaders and things like that. It's by showing your journey and showing that the results are really, truly self-evident. All right? So that's my journey. Let me show you my CT scans. Here I am in July. And you can see in July, it looks like I have a big gap, right? So the bone hasn't calcified yet. You guys can see that I legitimately expanded my nasal cavity. I'm demonstrating, proving that it was actually like bone structure, tissue, and here I am in December. I still have one more round of orthodontic treatment and some cosmetic dentistry to go, but looking good, feeling good. I don't wear a retainer, okay? That's like my biggest claim to success. I don't wear a retainer. My teeth are settled in. My posture feels good. I feel balanced. And I continue the amazing body work. And as I do that, I continue to see continued improvements and changes. All right? So let's make the diastema a little fun by sharing with you my journey on how cool it is to have this diastema. All right, so that was really fun. I hope you guys enjoyed that. Was it helpful to see kind of my personal journey going through it? Very, very good. So, okay, so where's the research? Is there any research on it? Anyone want to ask that question? All right, so here it is. This is by Audrey Yoon. All right, a roadmap of craniofacial growth modification development, published, I think, in the journal Sleep. All right, it's published. The whole protocol, starting with tongue tie, breastfeeding, myofunctional therapy early on, habit corrector appliances, removable appliances, implants, when to do it, all of our experience. Published in the journal Sleep, okay? Meanwhile, Audrey got viciously attacked by the orthodontic community for publishing this. Is it helpful for you guys to have an article like this when you're discussing with your patients? Yeah, amazing, right? You have an article publishing it. It's not just you saying something, right? It's actually been published. It's actually been demonstrated. But what we're going to learn is that the process of research always has a stage where you're first ridiculed, then you're viciously attacked, and then it becomes self-evident. And so what I'm going to propose is that when we're in the ridicule stage, you know that you're still early. And when you're being targeted and attacked, you should know that you're almost there. You're almost there. That's the perspective we want to take, okay? And so these cases talk for themselves. This is just tongue-tie myofunctional therapy. This was novel to us in 2017, 2018. Look at the amazing growth and development, right? Look at what we can do to help our kids. And I'm going to show you, not with research study, but with the decisions that I made with my own two kids, okay? Here's my son, Maxim, and here's Matisse. Maxim had a very severe, restricted tongue tie, okay? And when we're talking about tongue ties now, we're going to put them into three categories, okay? Good mobility. You guys know what good mobility is. It's grade 1, grade 2A, no compensation. That's good mobility. You guys with me? There's compensated mobility. That's the floor of mouth hold, the neck, the strain, the submucosal. And then there's restricted mobility, where it's just restricted. Are you guys good with me on kind of classifying the categories in that way? And perhaps that you can see that Maxim had a tongue tie that was restricted, all right? You take him to anyone, pediatricians, you hope, the parent can feel, that's a tongue tie, is a tongue tie, is a tongue tie. You guys with me, all right? And you can also see the impact that that had, because Matisse also had a tongue tie, but not as severe, all right? He had a more compensated tongue tie. And so for Maxim, we released his tongue tie within a week, his mouth closed, but Matisse had this open mouth posture. And the best way that I like to evaluate for these borderline cases in babies is the sleeping tongue posture hold promoted by Michelle.
Oh, darling, don't you ever grow up, don't you ever grow up, just stay this little. Oh, darling, don't you ever grow up, don't you ever grow up.
All right, so this is called sleeping tongue posture hold. Who uses this maneuver? Okay, you guys find it helpful? I find it really helpful. Objective is to get the tongue up to the roof of the mouth. You push on the submental area. You make that seal. You can do it on yourself even. You can feel it. Make that negative intraoral pressure clicking. You open the mouth and you see at what point will it drop. In Matisse's case, it's not dropping, okay? So this is a good sign that you don't maybe need to do anything. Totally elective, all right? It's also important to kind of qualify whether it's severely restricted, compensated, or good, so that when you tell the parents to do a tongue tie release, right, it's based on some objective findings, right? You never want to tell a patient they're probably tongue tied over email, all right? And that was the problem with the New York Times article. Parents that have breastfeeding issues, lactation zone said, you probably have a tongue tie, go get it released. That's a mistake on her part. That doesn't pass a newspaper test. You can't diagnose someone without examining them. That's on her. And she got caught. All right? And it affects everyone when you guys work out of protocol. So in any case, in this case, it's pretty good mobility, super elective. Not doing the tongue tie release isn't going to cause sleep apnea or other issues. So we first started with body work. This is Dr. Derek Nordstrom and his physical therapist, Kim. And, amazing unwinding, loosening of the tissue. And as we did this, two things will happen. Either the tissue will resolve, it won't be there anymore, or it will become more defined, okay? And we're seeing the same thing for orales and body work. So as you do the intervention, the fascia pulls away, and the frenulum becomes like more tight. Same with Kenalog. When you do the Kenalog post-procedure, you inject into that area. First, it's like a glob of scar tissue. You don't know where to release, where not to release. You hit it with Kenalog. The tissue starts to dissolve. Either it will be completely smooth, or you will now have like a defined restriction where you can go for a stage 2 procedure. Is this helpful insights for you guys? Okay. So in any case, the tissue is becoming more defined. We're able to do a really, really small release. And then amazing, he's got his mouth closed, okay? Less lip blisters and things like that. So for me, that was a major gain. Meanwhile, we don't want to terrify parents in the first year of life that, tongue tie is going to cause mouth breathing, it's going to cause brain damage and, growth development. You don't want to go there, all right? And the second thing to mention is that oftentimes babies have a difficult time getting that lip seal, not because of tongue and lip tie issues, but because their lower jaws are recessed. We have cranial strains. We're using swaddles and snooze to kind of confine the babies, okay? And you have a lot of fascial tension that's holding everything back. Releasing the tongue and the lip helps you compensate for restricted jaw mobility because of limited body mobility. You guys see that? In some other cultures, like India, for example, all the babies out of the womb get a finger underneath the tongue, and then they get oiled. The grandparents, great-grandparents come to get oil massages. Move. What do we do in the United States? Why does my baby move? Why isn't he growing? Well, why do you think, okay? You got to move the body to relax things and get things grow. And as the jaw grows forward, we see that a lot of the things that we think we're treating with tongue and lip ties are really covering up these jaw and fascia issues. Are you guys with me? Okay? So when they say the tongue tie is being a little bit overdone, it's not being thought out carefully. Okay? That's feedback. You gotta own that. Be like, They feel very strongly about this. What can I learn about this? How do I make this more specific? How do I know there's really a tongue tie there? And it's a tongue tie issue and not a jaw or fascia issue. You guys with me? And so that's where we're taking the research. We're not doing research to prove that it works. That's not the way that we do research, it's proving something. We do research to learn, not to prove. We know that we don't know everything. We know that this is investigational. And that's how we're going to continue to make progress in these areas. Questions, comments on these topics? You guys learning some stuff already? Just a half hour into it? Yes? Okay, very, very, very good. All right? So, the premise of all this is that half of what you learn in medical school will be shown to be the dead wrong or out of date. I have a colleague from medical school, Ashley. Where are you, Ashley? Where's Ashley? Amazing, stand up. Okay, we went to medical school together, right? 2010, right? It's so great to have you here. Did we learn about any of this in medical school? Not even close, right? Like tongue tie, breastfeeding, palate expansion. Was it possible to expand an adult palate in 2010? No. Okay? All right? So when people say there's no evidence for something, thank you, it's great to see you. There's no evidence yet. Because it's investigational. And we're on the forefront of things. Are you guys feeling me? Okay? Our clinic is on the forefront. We just got back from the ALSC Symposium, and we got all the updates that are going to be published in 5 years. We are 5 years ahead of the ASHA leader, ahead of the New York Times. Let me show you where the research is headed. That's how you're going to spin it. Do you guys feel me? All right. And so this is the process of research. And research means investigating to clarify the truth, to clarify, to see it better. It does not mean proving or disproving something. You can't use a research article to disprove that palate expansion doesn't work. You can't do that. I showed you with a case report that it's possible. There's no research that can say that it's not possible. And we're already beyond that. And so let us consider that all truth passes through 3 stages. First, it is ridiculed. Are you guys with me? Second, it is violently opposed. Third, it is accepted as being self-evident. And so as I share these concepts with you, the first thing I'll say is that probably I'll come next year, and there'll be some changes, and I'm proud of that, okay? We're going to clarify things, we're going to get things better, so, stay tuned. But also, I want to share this case with you. Have you guys seen this case from Katerina? Let me share it for a second, okay?
Hi, my name is
This from
Katerina Wittisch,
2017.
and my father's really tongue-tied, can't use his tongue at all, and I had a frenectomy when I was 7 because I was tongue-tied, and it didn't make much difference. My tongue looked sort of normal, but I've had really bad headaches my whole life. I have scoliosis, a lot of jaw tension, a lot of problems sleeping, and I had been told that perhaps I should go see an oromyofascial specialist, but I hadn't done that. I actually had to do a palate expansion because I had such bad sinus infections all the time, and I didn't want to do sinus surgery. And the palate expansion helped, and it helped the headache somewhat, but not entirely. It got rid of the sinus infections, but I still have a very small palate. And eventually after that, I decided I would go see Joy Moeller, and I would go have an evaluation. And she suggested right away when she saw how I was swallowing that many of my issues, including the not sleeping, including the constant headaches and the TMJ, might really change if I had a deeper frenectomy, that my adhesions, I don't know what you call them, were deeper in and were submucosal, and that they had not been disconnected in the first surgery. So I came to see Dr. Zaghi, and he agreed that this would make a big difference. And I had a tremendously forward neck when I came to see him. I was sort of like this all the time, and lots of tension all the time in the jaw, the back of the head, constant headaches. And the experience of the surgery was really amazing for me because I was scared of it because I'd had this botched one when I was 7. And Dr. Zaghi and his assistant were incredibly present and kind and informative, so that it wasn't so scary to do. The actual procedure was not painful or difficult really at all. But what amazed me during it was I had a need to go pretty deep to cut the cords. So what was amazing to me was that the first layer of cords, I didn't feel much, and I thought, oh, I'm going to be the one person this doesn't really change. And then the second layer, I started to feel this opening in the back of my neck, in particular where the neck connects to the spine. But the third layer, when he clipped them, it was like everything in my head and back opened up. And so now you can see that the way that I hold myself is completely different. This would have been impossible before the surgery. So in 1 second, there was this feeling of, oh, everything opened up. The pressure in my jaw is gone. The pressure in the back of my head is gone. All kinds of possibilities are opening up. I've had a little bit of a dance with my scoliosis.
And this was in 2017, 7 years ago, where something like this had never been observed, never been documented, never been communicated. Since that time, who has had a patient just like this? Let's see, show of hands. Amazing, right? Almost everyone in the room, and we see this like on a daily, weekly basis, all right? And we've really figured it out just the other day, that girl who came in and had such an amazing release. We figured it out. What are the essential components? The preoperative myofunctional therapy body work, how deep to go to prevent any kind of bleeding or salivary gland or nerve injury, the post-operative protocol. And would you guys agree that it's now pretty self-evident that tongue tie can affect things like fascial restriction, TMJ, mouth opening? And so we have to really kind of consider that. Here she is 2 years later. Now, when this research is emerging, you have one of two options. One is, that's really interesting, let me learn more, right? And there's a lot of you here who are like, wow, that's amazing, let me come study with you, let me come learn. That's one approach. The other approach is to say, it's impossible, this is not science, and let's not do it. And so that's the feedback that I got. This is back in 2017 from Eric Kazarian. And the first thing that he did in this process of research is what? What's the first stage? Ridicule. He ridiculed me. He made fun of me. He called me up and he said, what are you doing? What a joke, okay? You're better than this. What's this testimonial? Get out of here. Go get better research, okay? So that's what I did. I went and got better research. And then you know what happened? What's the second stage? Violently opposed. He took out paid Google ads to my name, okay? Like $1 per click, Soroush Zaghi, okay? Breathe Institute, Westwood, okay? To this post. Sleep apnea is serious. Don't do myofunctional therapy. It's dangerous. Don't do a tongue tie release, okay? There's nobody who would recommend this except one person. Enough is enough. It's time for someone to speak up. There is no proven benefit to myofunctional therapy or tongue tie as it is practiced in the United States. If you're interested in doing this, go to Brazil. What? He literally says that. He says, go to Brazil. Well, I have some exciting news for you, okay? Time has passed, and the research is there. The research is here to support what we're doing, okay? And the research shows of 2019 that yes, tongue tie surgery can help with mouth breathing, muscle tension, snoring, clenching, and grinding. And guess what? This article is top 3 downloaded and referenced article in the journal Laryngoscope and Musculoskeletal. So think about what that research process has done for all of your patients in all of your communities. And I'm jazzing you guys up because there's still a lot more work to do. And we really have to look back and reflect on where we've come from and stand proud with our successes so we can have the energy to push forward. And so there's a lot of people that go behind the scenes. So I just want to give a shout out to our amazing clinical research team at the Breathe Institute. Thank you guys so much for working tirelessly. Laylee and Chad were up till like 11:30 or 12, getting the final touches on our newest research on wound healing, integration, and maturation, which is really going to transform our results. This is the number of publications that we have since 2017, okay? showing you how busy we are. Thank you guys so much. And so we're really in a new era. It's a dawn, it's coming. And I also want to give a shout out to all my amazing affiliates. Where are my affiliates in the group? And my ambassadors for replicating this, for being playgrounds to retest and test these ideas, because it's not enough that I can do it in my clinic. You have to be able to do in your clinic according to the protocols that I give you. And so we give you these protocols, you guys try it out, you say what worked, you say what didn't, we come back year after year, and I can't believe how much we've achieved just in the last year alone, and I'm excited for what 2025. Who's excited for Florida 2025, yeah? You guys gonna be there? So no matter what people tell you, words and ideas can change the world, but let us remember that all truth passes through 3 stages. Say it with me. First, it is. Second, it is. Third, it is accepted as being self-evident, okay? And I want you guys to remember that when you see challenges and controversies, okay? And this is the most important part. I was like building up to this moment, okay? You were doing the work, you're seeing it. Look at me, look at my kids, look at your patients. It's right there, all right? Yet people will come, like there's this one girl who's stalking us, Brianna Milok or something like that. Who is this girl? She publish anything? Every time you publish something, she comes out, oh, there's no evidence. There's no evidence, okay? This is January 22, 2024, and poor thing, I'm so embarrassed for her. She put online that tongue tie, there's no evidence that tongue tie causes feeding or speech issues. I feel sadness for her, okay? This is not gonna affect my patients in my clinic, all right? I see this, I'm like, what do you think about this article? I'm genuinely sad for her. What a missed opportunity to really help her patients. She has a platform and she missed the target on this, okay? What are you saying? There's no evidence, okay? And second of all, lack of evidence is not evidence. Lack of evidence means, yeah, lack of evidence is not evidence, right? Lack of evidence means you don't understand. So you publish an article, it's 2024, everyone, okay? And I don't know about tongue ties and feeding and speech issues. You sound ridiculous. There is no high-level evidence yet, but this is the way the research is headed. We're on the forefront. When the patient, what do you think about this article? They're right, there's no high-level evidence yet, because our clinic is on the forefront. We invest in our continuing education. We go back year after year. We contribute to research at this center. You guys see how we're turning the language around? Okay? That's the way we want to target these things. Because the research and treating your patient like a puzzle. Some of these puzzles we figured out. I get these poor patients coming in, their heads forward, TMJ, 28 millimeter intermolar width, tongue tie. So excited I can help them, right? We got these figured out. But there are other cases we just don't know enough. We just don't know enough. How about these patients with connective tissue disorders? Okay? What do you do for them? How does that work? Okay? And it comes to pass that there's a lot of patients with these minor, different kind of syndromes and issues that the only way we can study them is if all of the patients come together into a pool. Okay? So the next stage of our research isn't going to be just what we can see from the top, but how do we get deep, deep, deep in there? And we've been working for the past 3 years on a platform called Breathe Insights, which is going to be for everyone, therapists, doctors, everywhere. You put in the patient puts in that they have like Marfan syndrome, or they have Ehlers-Danlos syndrome, or that they're pregnant, or they're taking this medicine, or they're taking that medicine. And then everyone puts it into the system, so I can go and query, hey, 50 Ehlers-Danlos patients, how do they do? Right? 100 patients with this connective tissue disorder, pregnancy, narrow palate. Think about the power we'll have, right? If we all come together in that way. And so one of the biggest challenges so far has been collecting the data, but I'm really, really excited for this Breathe Insights platform because it's going to facilitate your op notes, your procedure notes, your consult notes, informed consent, legal medical considerations, billing, everything designed specifically for the work that we're doing, and it's constantly updating and adjusting. So this is funny. Linda D'Onofrio posted this on the Myofunctional study group. Okay, it's a little cartoon here, and the individual is doing a poster presentation, and he says, "I have attempted science." So the instructor says, "Please explain." "I formed an idea, and then I discovered I was wrong. There are numerous diagrams. I was wrong in numerous ways. I produced a detailed tribute to my wrongness." The lady goes, "That is science." Okay. Love that. Love that. For two reasons. First of all, that is science, okay? Science is saying, hey, I taught you guys how to go deep with scissors 7 years ago. You don't have to go so deep. You could stay more superficial, okay? We talked about, dome procedure, and now we have like MARP-B, which is easier and more fluid. And so the most important thing to recognize is that science is about continuing to learn. And we have a lot more progress to go because this is a patient that I just saw in the clinic. You can see that he has the compensated form.
Okay, go ahead and show me your teeth. Good. And open up your mouth. Open big, big, big. Lift up your tongue. Okay. And so what are they doing for your orthodontic treatment? What are they doing? Mom, what are they doing for him? What are they doing so far?
They are trying to fill in the spaces that they pulled 4 teeth out, 2 on the top, 2 on the bottom, and now they're trying to fill in the spaces.
Got it.
The space.
And you guys didn't want to pull out the teeth?
Not at all. Not at all.
There's no other choice.
No, we had no choice.
Got it. Smile for me again. All right. We're going to take you for some referrals. Okay, buddy?
Okay.
All right. So sad, right? So unfortunate that in 2024 we have to have this. The first thing I want is for mobility. We're describing them in 3 ways now. Good mobility, compensated, and restricted. Okay? That's just kind of globally. Then you can do the measurements, floor of mouth hole, TRMR. This is a grade 3, compensated a grade 2. Are you guys with me on that? We're going to go over that in a second.
Okay, go ahead.
All right, expert consensus statement. How to treat sleep apnea in kids after adenotonsillectomy. You know what the treatment is? It's tongue-based resection. Okay? It's cine MRI, sleep endoscopy, under sedation to cut out the back of the tongue. What about palate expansion? What about tongue-tie surgery? Not mentioned on here. What they're advocating for in pediatric sleep apnea, currently in the ENT Society, is tongue-based resection. This is it, okay? If you fail to cure sleep apnea, what do? Cut, all right? And we ask, hey, is there a better way? So we show people, hey, look at Myo, look at tongue tie. It's easy, it works. But some people, tongue up, lips closed, healthy breathing through the nose. Are you guys with me? Chewing and swallowing is needed to grow. I made a lecture, okay, outlining all the long-term implications of untreated tongue tie with a balanced look at the research. If an article comes out like these New York Times articles, instead of getting reactive, you post, today is a good day to share this article. Today is a good day to share this YouTube video, okay? Do not repost the article. Do not, can we get some, you guys got it? Do not repost the article. Do not take advantage of the situation to get more followers on your account. Why do you feel like you have to respond today? You're trying to be exciting? You're trying to be novel? This is a travesty, these articles, okay? I was really affected by this because I was interviewed for this, okay? I made myself available, like my time with my kids is precious. I went through my entire presentation, hour and a half, laying out all the evidence, qualifying it, telling them, hey, listen, you have a big platform, okay? You can really, what you're gonna say is really gonna make a big difference. And ultimately, everyone's seen this article, right? Yeah. You know, a lot of disappointments, but the biggest disappointment to me was the reactivity I saw, okay? Was the, oh, did you see this article? Posting it, getting shares, people coming up with the white screen saying, oh, this article, follow me, follow me. That's not what you want to do. This is a travesty, this is a sad situation. So today, we're going to post an article, one of Dr. Baxter's articles, one of Dr. Zaghi's articles. You're going to ignore it, you're going to let it go down. Because if you look at it, if you post it, if you repost it, all of your followers will see that post. Every time you comment on it, it goes higher and higher and higher. And then it gets picked up by the Atlantic, and it gets picked up. What are you guys doing? Let it go. Calm down. It's behind a paid wall anyways. No one's gonna see it. Give them a low review. Pump up the investigative otolaryngology, top 3, right? Your views, your algorithms matter. Don't promote it, don't share into it, don't be reactive, share a different perspective. Today is a good day to share this article. Someone else posted an amazing article by Dr. Baxter, myself, whoever else, Dr. Agrawal with the flip. Post those articles this day. Ignore it, let it go. But is Dr. Scott Siegel here today? Okay, but round of applause for this man, okay? Round of applause. Wow, 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 wow. Man, my heart goes out to him. He was subjected to the newspaper test. Have you guys heard of this? Okay, and the newspaper test is something that you guys should consider every day that you do something in your patient, new intervention. It's by Warren Buffett, and the idea is that if what you were doing right now was exposed by the New York Times, how would you feel? What would you think? If a patient messages you, I have these symptoms, do I have a tongue tie? Yes, you definitely have a tongue tie. How would you feel if they got picked up by the New York Times? Is that the right thing to do? How would you feel if the New York Times picked up a picture of you at the Tequila and Tongue Ties conference? You guys see this? So it's a not-show average dental meeting. This is a real conference by BioLays. You should be embarrassed to go to this conference, right? Here we are, new research, evidence, study club, how can we improve, okay? This doesn't pass the newspaper test. Dr. Siegel does pass it. The article was clickbait. I'm gonna believe to myself, the person who interviewed me believed me, and it was the editor that made it so nasty, okay? That's like my personal, I don't know, but the facts in here aren't bad. It was the way that was spun. Dr. Siegel's been practicing for 2 decades. Amazing. That passes a newspaper test. He sees up to 100 patients a week. He doesn't charge an expensive fee, okay? There's a lot of follow-up time, energy that goes into these things. He invited them to watch. He's not doing it behind closed doors. It's an open kitchen concept. He's like, come watch me do it. Before each procedure, he did a complete informed consent. He did a thorough exam. That's what they're saying here, right? One mother came in and did a lot better. He's being honest about the research. We're looking to be proactive, not scaring them. He used, protective glasses, and he, suctioned out the plume. Amazing, amazing. He acknowledged that few studies support this. He has thousands, hundreds of 5-star reviews, but not everyone's satisfied, and that's true too. It's 99%, 97%, not everyone's gonna be. And he has low complication rates, right? So round of applause, okay? So in a way, the article is, violently opposing it. But the facts that they have all stand up for themselves, and he passes the newspaper test. So people asked me, what do I think about this? And so, I think that we have to take a more nuanced approach to these things, remembering that all truth passes through 3 stages. First, it is ridiculed. Second, it is violently opposed. And then it is accepted as being self-evident. Any questions or comments on this approach? Okay, so that's why you guys saw me. People said, what do you think, Dr. Zaghi? What does Breathing Institute think? I said, we're not going to respond to this. All right, I'm going to wait, come in the right platform, really think it through what I want to say, and that's what we're going to do. And I'd encourage you guys to kind of reflect on that and do the same. All right, so now let's get to the meat of it, all right? Tongue-tie diagnosis. One of the biggest problems is that people don't know how to diagnose baby tongue ties. It's a major problem if you rely only on symptoms. If you can't show them it's a tongue tie, what are you doing? That's a major problem in our society, in our current platform. So for adults, we've done a lot of research, and we've shown that, the Kotlow free tongue measurement is good, but there are individuals that fall through the gaps on these. The Carrillo's classification is not going to tell you if they have a tongue tie or not. It tells you where it is and the chances of it, but this doesn't tell you how bad the tongue tie is. It really doesn't tell you anything. It's just describing it to you. TRMR is helpful, but also limited. And we've lectured on this in prior years, all right? What we're finding to be the most helpful is, and then so this is showing you that first of all, TRMR is not applicable to under age 12. So those measurements, the average is 50% for 3 to 11. All right? The most useful tool to diagnose these things is a finger in the floor of the mouth. So we're changing the assessment to 3 categories. Great mobility, you put your finger there, it doesn't, the tongue goes up nice and easy. It's clearly a grade 3 or 4, or compensated mobility. You guys got that? That's kind of where we're moving. And this floor of mouth hold works in adults and in babies. All right? In addition to the sleeping tongue posture hold, you're going to demonstrate that there's a posterior tongue tie. And what is a posterior tongue tie? We're going to change that at this meeting. Okay? And we're going to talk about mid-tongue elevation. Okay? Because the term posterior is a little confusing for ENT doctors because the posterior tongue is supposed to be down. The back of the tongue, the base of the tongue is down. So when you guys are talking about getting the back of the tongue up, they're like, do you even know anatomy? The back of the tongue is down. And we're going to spend a minute talking about that. Let me guys show you this. Who here has used this maneuver? Who here finds it helpful? More helpful than TRMR? Are you guys with us? Okay. It's like 99% sensitive and specific for...
your tongue for us?
We're going to publish it this year.
Lift up your tongue. Okay. Lift up the tongue to the front of your teeth. Okay. So you can see that it looks like a grade 2 tongue mobility, but really she's bringing up her entire floor of the mouth. And if we hold her floor of mouth down, or it should be, and ask her to lift up, you can see she can't get it up. She just cannot get up her tongue, and you see the dimple right here. That reflects the side of the frenulum attachment point.
Okay. So we're seeing where the restriction is, and it's been published by Juan Moon, and we're going to publish it again this year. And this is where the posterior tongue tie is. But this is not the posterior tongue. The posterior tongue is back here. These tongue ties are affecting the posterior part of the anterior 2/3 of the tongue. Let's clarify that. All right? The posterior 1/3 of the tongue, based on ENT literature, surgical anatomy, dentistry, is behind the circumvallate papillae. It's that little ring of tissue. That part is attached to the hyoid and it's down. The part that we're talking about is the anterior 2/3 tongue. Are you guys following me? And a posterior tongue tie is just behind the first 16 millimeters. So really, it's more like mid-tongue elevation. Are you guys with me? So you have a problem with mid-tongue elevation. Now it's difficult because the literature already has the term posterior tongue tie, but it's kind of a misnomer. So for the next few years, we're going to carry them together, and then we're going to let go of posterior and talk about mid-tongue elevation. Are you guys with me? All right, so why is it mid-tongue? So here's a 8-year-old boy, and you can see that the front, he just drank some Gatorade, and he's swallowing, right? And the tip of the tongue is clearing it off. But what about that mid-tongue? Is that going up? No, it's not clearing it up. This is done with Gatorade. I also sometimes use fluorescent dye to kind of show it. You can put ophthalmic fluorescent dye on the tongue. We saw it together, doctor. And you ask them to swallow, and you can see if the tongue is going up in the middle of the palate and if the food is being cleared. But this
so let's take a look. Open up your mouth for me. Good. Lift up your tongue. All right. And let your tongue go down. And stick out your tongue. Very, very, very good. Lift up your tongue one more time for me. Good. Rest your tongue. Good. Lift up your tongue. Fantastic. And stick out your tongue one more time. Excellent. Excellent. So good.
Okay. And then just for like the description of it, just so we're on the same page, what would you guys say? Good mobility, compensated, or restricted? Restricted. Okay, this is restricted category. And it's going to be important to classify it in that way for our future research, okay? All right, so I've shown you guys this case, okay, where the tongue isn't getting up. Here it is before and after. This is, again, emphasizing, the mid-tongue, just right behind the anterior 1/3 of the tongue. So I just want to take a pause here. What should we call this? Any thoughts, questions? Should we call it? It will take a couple minutes. Posterior tongue tie. Does anyone else have any other ideas that they like better? Mid-tongue restriction. We'll put that out there. Mid-tongue tie, you want to just go for it, huh? Mid-tongue restriction. Give ideas. We're taking notes. We're going to take notes and we're going to practice these things out. Other ideas? Sometimes this is not submucosal though. So this is not, this one, these are not submucosal. Right? So submucosal doesn't work because this is, he's compensated. He's compensating. And it's affecting the you know.
And lift up your tongue.
See, it's that mid-tongue elevation.
Lift it up.
Even though it's not submucosal. So are you with me on that?
Go and lift up.
Any other suggestions for what this could be called? Mid-tongue restriction. What else? Mid-blade. Who's commenting? I can't see. Okay, yes. Mid-blade restriction with low tongue posture. Okay, but we're kind of getting on the same page, right? And we're understanding that it's just behind the tongue tip, in the body of the tongue, and I think the blade's is it the tip? Yeah, I think it's right behind it, right? So it's the body. So not so you have the apex, you have the tip and the apex that makes up the blade is the side, and then you have the body. So it's mid-body restriction. Again, let's take a look at this anatomy figure and make sure we're on the same page. All right, so you have the apex of the tongue, right? Then you have the body of the tongue, and it's really like in the middle of the body of the tongue. The apex is just the first like little 12 to 16 millimeters, all right? It's right behind there. What is it? Apical? Yeah. We'll write it down. Hey, we're gonna, this is where new ideas come from, right? Yeah, all right, very, very good.
All right,
so if you have other ideas, feel free to email me or let's have a discussion about it. Yes, please. What's that? Yeah, so ventral, dorsal, so we have ventral coming up. I like that, and we have it coming up, okay? So the way, this modality of assessing for the posterior tongue tie. All right, so now is this one good mobility, compensated or restricted? So if you have a positive floor of mouth hold maneuver, we're calling it compensated mobility. Okay? So in this case, all right, first of all, we're calling it depression on the dorsal surface of the tongue. The ventral's on the inside of it, okay? So you're seeing a DDT, depression on the dorsal surface of the tongue. And should you treat it, all right? If you're like a significantly restricted, then you say you're high risk of, what's up? No, it's not, the tie is in the middle, so yeah. Yeah. So if it's like this and it's compensated, you want to be nuanced with your treatment recommendations. If it's restricted, you can say, yeah, these typical tongue ties affect chewing, swallowing, clenching, grounding, mouth breathing. The ones that are compensated are very common. 50% of the population may have these kinds of tongue tie, all right? Meanwhile, only some patients are symptomatic. So if it's grade 3, 4, severely restricted, encourage release, recommend. I am the doctor, I went to a conference. Based on my expert opinion, I recommend treatment, okay? The second option, it's elective. The third option is you could, but I don't know, maybe recommend not, all right? Yeah, please.
I would say, what's the arch development right now? I don't care if there's tongue, I do care about the tongue, but if they're already developing malocclusion, there you are. If they have a speech problem, there you are. Do the tongue, watch the tongue free itself up.
That's a little dangerous though. So you can't diagnose a tongue tie based on the effects it had because tongue tie is only one cause of low tongue posture. It's only one cause. So mouth breathing, adenoids, tonsils will cause the same. Okay? And so I appreciate that comment, but that's the kind of thing that gets in the New York Times. Yeah. We'll talk, okay? But I'm glad you mentioned it. But you cannot diagnose a tongue tie based on the fact of the high narrow palate. You can't do that. The tongue tie has to be in the tongue function, not in the results. You can't diagnose it based on symptoms. Symptoms might suggest it, look a little bit deeper, because tongue tie is only one cause of low tongue posture. You can also, if you're not sure, you can exclude the other ones. I did a CT for tongue space. There's no tonsils, adenoids. I did the myofunctional, still restricted. I feel a little something. It might be a tongue tie. You can also make it a diagnosis of exclusion, telling the parents, we tried everything else, you might as well try this. But not your first thing to go to. Yes?
So we know that tongue posture is critical in maxillary development. So what else is, when you see a high narrow
Fascia issues, swaddle, bottle feeding, allergies, milk protein allergies. For sure, much more. 90% of the babies that'll come to you will have a tongue tie and you'll release it if you're in that kind of modality, if you're in that kind of mindset. And a lot of them don't have tongue ties. You have to tell yourself, you have to admit to yourself that you've released some kids who weren't really tongue tied. If you've done 10,000, 1% of the time you were wrong. I'm wrong probably 5–10% of the time. If you think you're 100% correct 100% of the time, you're not learning anything. You're not growing, you're not developing. How can you get more sensitive? How can you get more specific in your approach? All right? All right, so you're going to tell them to relax, hold the floor of mouth and lift. You're going to look for a visible depression on the dorsal surface of the tongue. You're going to see, is there a physical restriction affecting mid-tongue elevation? It's not enough that they can't get it up. If it's weak and it can't get it up, doesn't qualify. It has to be a tightness that you feel that's not getting better with therapy or body work. All right? Let's take a look at this case. So this is a compensated form. Good. You got a good video? Lift up your tongue. Good. And do a suction hold. Good. Drop your tongue down. Open up your mouth. Lift up your tongue. Lift up your tongue. All right, so you guys are seeing that? We're good on this topic, right? The depression, dorsal surface of the tongue. You tell them, again, let's go back to it. You guys have the slides too. Relax. Hold the floor of mouth. Lift. Look for that cupping, dimple, or depression. DDT, depression, dorsal tongue. Okay? All right, so I'll remind you guys about this case. Open up for me. Very, very good. Lift up your tongue. He has a narrow palate. Good. Show me your suction hold. Good. And then put your tongue into the back of your throat like you just did. That's amazing. Okay. Well done. Would you bring it out? Do it again. He has a narrow palate. No, if it's a narrow palate, expand his palate. Yes. Suction hold. Hi, Bridget. All right. You want to push sublingual caruncle. So if I did it that way, it's because I was trying to take a picture. You're going to push in the sublingual caruncle. And also knowing that is going to affect your surgery because you'll do your surgery in a way that is separating the tongue from the floor of mouth, which is the goal of the intervention. Good? It works, but it's hard to really assess. Yeah. So at the time of surgery, it's a little bit hard. The baby's crying. You're not getting the best. But in an assessment, if you're assessing, you're not sure, you hold it down and you see a tight restriction. You've shown the tongue tie. You show the mom, hey, look, when they stick out their tongue, they have the milk tongue in the back of the tongue. It's right where the restriction is. You're proving to the mom that there's a restriction. You got to prove that there's a restriction. New York Times won't come after you. Often email, go get released because you have these symptoms. That doesn't cut it. That doesn't pass the newspaper test. And the more successful you get, the more scrutinized. They're waiting for you to slip up, right? All right, good, good, good. All right, so what about tongue space issues, all right? So we said that you want to be more than, most people are 34 to 36 millimeters. If you're less than 32, if you're really narrow, you can get worse, especially if you have a diminished posterior airway space. After the break, we're going to talk about how to assess tongue space. If, you do these procedures and they have a narrow palate, they can bite and clench on the sides of their tongue. And we're using the LPS palatal overflow because you can get complications like this one. This patient didn't have enough tongue space. You go in there to do a deep release, it swells up a little bit, and then you get more and more complications, ischemia, diminished blood flow return. So let's remember it's tongue tie, tongue tone, and tongue space. And if you identify the tongue tie and the tongue tone, okay, you're good. But if you miss the tongue tone and the tongue space and only focus on the tongue tie, you're not going to be in a good place, all right? So let's take a 10, 15-minute break. We'll be back at 10:30. When we come back, I'm going to show you the new technique. I'm going to show you Kenalog. We're going to go over soft palate and tongue space research. Thank you guys so much for coming. We're going to come back at 10:30. Welcome back, everyone. Welcome back. Very, very good. Thanks for... All right, so hope you guys enjoyed the first hour and a half of the lecture. Thanks so much for giving me this platform. And I think on the break, where we're headed is a mid-tongue restriction, okay? You guys feel good about that? Mid-tongue restriction, okay? So what's that? Yeah, it's clean. So every year we come here, we get your little 2 cents. We're going to get your 2 cents on some things here. But we're moving away from posterior tongue tie and introducing mid-tongue restriction, which equals posterior tongue tie. And then in 4 or 5 years, we used to call it posterior tongue tie, now mid-tongue restriction. Or mid-tongue restriction, AKA posterior tongue tie. Not submucosal, because submucosal refers to where it's attached. Rather, there's a restriction, like a physical restriction, not a weakness, not a tongue space issue, affecting mid-tongue elevation. Very, very good. All right, so, we showed you this article and the amazing results we got, right? It's incredible to see this reproduced. I think we have like 2,500 ambassadors, over 60 affiliates who are doing this work. And, it's one of the top 10 downloaded articles from the journal Laryngoscope Investigative Otolaryngology. Having you guys download our work and cite the work makes it more likely that we can continue to publish in those journals. Meanwhile, the prior way that we were doing this was associated with a lot of complications. Pain, bleeding. 13% of my patients would bleed for more than 24 hours, would have some bleeding, and 2% for more than 24 hours, okay? The prior version was with just scissors approach. I had some numbness of the tongue tip for 2 weeks, about 5%. 3% were numb for more than 2 weeks. Those are some complications, guys, okay? Some salivary gland injury, and so we decided, hey, what can we do to make things even better, all right? Since that time, I've moved to an approach where we're using like laser and more refined examination techniques, including the floor of mouth hold, to guide the depth of the release. So, if I were to ask you, in what proportion of cases of mid-tongue restriction, okay, that's the compensated one, the posterior tongue tie, all right, is the muscle involved? What do you guys think? 100%? 50%? Yeah, comes out, it's about 50%, okay? And the muscle can be involved to different extents. Oftentimes it's just a little bit of fascia. Other times you have to go quite deep. But in my hands, the muscle's involved about 50% of the time, and I'm not stripping the muscle and getting every little bit. The more you go into the muscle, the more contraction you get. And I had some questions about what's the best stretching protocol, okay? How do we show that Kenalog works? What about serapeptase? What about vitamin E oil, all right? And the common denominator to all of these, the common denominator is that we don't have a way of assessing our wound healing results. You guys see that? So today we're going to demonstrate to you guys the wound healing integration and maturation scale. And then what we're going to do is we're going to try different stretching protocols. And we're going to rate the patients according to these scores at 2 to 6 months. And we're going to say, hey, when you do the stretching, when you don't do the stretching, when you do the Kenalog, it's objectively improving the quality, integration, and maturation of the wound. Does that make sense? That's how we're contributing to that research. All right. So, I want to save some time, but basically you have the patient lift up their tongue or do a lingual-palatal suction, or you assist them in doing so. The prior version was with scissors, but basically you make a small opening, and you can see that the small opening is now a lot smaller and more confined as compared to before. So this is like the kind of depth of release that I get now as compared to Katarina Winich, where I was going in there deep, releasing all the muscle fibers. Most of my incisions are very, very, very small. The smaller the wound, the smaller the scar, okay? If they have myofunctional issues, it's a struggle, so doing the myofunctional therapy beforehand can certainly help, all right? Let me show you how I used to do it and how things have changed a little bit, all right? So before I would do like a hemostat, I still do. I now curve the hemostat a little bit lower because the objective is to separate the sublingual caruncles down and the tongue up. All right, so I'm going a little bit lower, but don't go so low that you cut through the sublingual caruncle. All right, if you go too high, well then it's still going to be attached to the sublingual caruncle, and your floor of mouth hold will still be positive. Are you guys with me? All right. I know this is kind of fast. We only have an hour and a half, but I'll give you everything I have. We have the lecture slides. If you want to take the annual Breathe update course, it's about an 8-hour video on demand that you guys can learn, or you guys can come and shadow spend more time. All right. So before I would go in there and I would pick out fibers. Okay. I would pick them out until it was all clear. Not doing that as much. The end point now is what? Floor of mouth hold. Tongue getting up. That's it. All right? You're not going to strip every piece of mucosa and fiber and every last strand because not necessary for the outcomes. The less deep you go, the better result you'll get. So you'll see before I had like a lot of sutures here, and here's the new updated approach, okay? We start by determining, is this good mobility, compensated, or restricted? Which one is this going to be? Okay, it's compensated, all right? And you can see that in the floor of mouth hold, it's like mildly compensated, all right? It's not terrible. We give the injection to that area. Okay, hemostat clamp. You'll notice that I'm kind of pointing downwards, trying to separate the sublingual caruncles from the frenum, pushing the sublingual caruncle towards the floor of the mouth. I do a little bit of a pushback. See how small my incision is? All right, I get a Q-tip in there. That's it, okay? Lift it up in butterfly. Make sure the muscle is like kind of deep to the ventral surface. The muscle's not sticking out when I lift it up. Check the floor of mouth hold, much better. All right, and that's it. That's my release. I'm not digging in there, trying to get that fascia out. There is a fascia band in there. You guys see it right here, okay? I'm not fishing out the medial lingual septum like before. You've reached your objective, all right? Then you would take it a little bit. And just the fascia at the bottom, and the muscle will release. You're trying to preserve as much muscle as you can, okay? So as little fascia towards the bottom, towards the sublingual caruncle as you can, all right? And a couple sutures, fewer sutures than before, and between the sutures, I'm using periacral glue. The sutures introduce inflammation, all right? And they also cause a little bit of wound dehiscence as the tension can sometimes tear. So a couple of sutures and periacral glue, we get great healing. All right? Let me show you, and then we can take the dog out either with scissors or we can ablate it on the dense frenum setting, okay? So that's where the frenum was attached before. All right? So much more minimal than before, okay? Here's how you do the periacral glue. In between the sutures. You guys seeing that? Just a little bit. The littlest bit. Okay? Then you use a dry Q-tip. This works.
Very, very good.
Anyone using periacral in their practice? Finding it helpful? Okay? Fewer sutures, a little bit of drops of periacral. You guys saw that? Look again, how little I'm using. It's like not even a drop. You guys see that? So you're like 0.1 mLs, 0.05 mLs, like throughout the whole thing. If you do too much, it gets crusty and it's not so nice, okay? Here's what the final result looks like. We confirm it with the floor of mouth hold maneuver. The floor of mouth hold maneuver is like the most important to me. Even when I check them afterwards, floor of mouth hold. If you're good, then you don't have a mid-tongue restriction. All right? And then we ask him how he's doing.
All right, Ethan, thanks so much for participating and allowing everyone to learn from your case. Tell us what you experienced during the procedure.
It was very stress-free. Didn't feel any pain. I noticed a lot more mobility in my tongue after procedure was done. I was able to actually touch my tongue to the roof of my mouth comfortably. And yeah, that was everything.
Amazing.
Okay, so he's getting his tongue up, swallowing better. You get the same cathartic changes. Everything, you get the same outcomes. Less complications, less bleeding, less pain, better wound healing. Has anyone tried the more minimally invasive approach yet? Any comments? Yeah. Amazing, same great results. Any other comments? So much less and amazing. So better patient selection, right? More minimal technique, better results, passes the newspaper test, right? Amazing. Any other comments? Anyone? Yes, please. It takes getting used to kind of back off a little bit, right? Yeah. Good. All right. So I'm using the scissors more, the laser more and more. Here are my settings that I like, okay? I added an upper lip dense frenum setting. If you have the lecture slides. Also, if you go to my website, Zaghi MD, and you go to educational resources, you can also get the PDF there if you ever forget the settings. But these are my most updated settings. My favorite setting is the fascia setting. The fascia setting has the least contraction, okay? If there's a blood vessel, something like that, fine. Use the muscle or frenum vascular setting, it's all good. If you're not sure, settle for the mucosa setting. In babies, I probably do mucosa setting. Unless it's bloody, I'll do muscle. Fascia, you may get some bleeding because it's not drying it up that much, okay? But it slices through the fascia layers and doesn't dry it up. If you put too much heat, the fascia dries up, and then later on, you get a more contracted, thicker wound, all right? And it delays the integration and maturation process. Are you guys with me? Good. Do I like to use sutures? Yes. Okay. The smaller the wound, the smaller the scar. But I'm using fewer sutures, but yeah, for sure still suturing. I don't like PTFE anymore. I don't like it. The reason is that it tears the tissue. So you put it in there, they lift up their tongue, and then it tears through. Okay? And now you have a big wound. The chromic, at least, you put a couple. If they stretch their tongue, first of all, the periacral glue is helping to keep it together. And also, they fall off after a few days. So with the mobility, like you're going to be all square away. I have to acknowledge Jenny Chang for teaching me about the surgical glue. Is she in the room here today? No? Okay. The initial way was just to squirt it in there. That's not the best way to do it. The best way is actually to push the wound together. This is periacral glue, where you get it from. Again, just a little bit, okay? If you get too much excess, it spills around, you can wipe it away with a wet. But if you got precise, you just dab it with a little dry, and you should be good, all right? You don't want to squirt it in there. You want to get the wound edges together. You can use it on babies, all right? Upper lip tie, tongue, just a drop. Like almost nothing, okay? Like you fill pipette, it's just like a little bit of a drop. If you put too much, it gets crusty, and then the crust falls off, and then it bleeds, and then it's like, it's all over the place. You dry it up real good. You dry it up with a gauze. A drop, dry Q-tip, you're done, okay? Any questions about that? Yes? No, there is Dr. Pia Gandhi who uses sutures. The technique is very challenging, okay? It's technically difficult to do, okay? So I'm not advocating for sutures. I'm advocating for, if you're thinking about it and are interested in doing it, I'm not saying definitely do it, but you can safely use periacral glue on infants is what I'm telling you. I have done it on infants and it's been safe. If I take them to the OR, I use sutures and glue. In a baby, so you want to keep the wound as small as possible, okay? And in a baby, you're keeping the wound small. You're pinching it together and then putting just a drop, like where the muscle is, where that little opening is. So you're just kind of laying it in there, okay? Just a drop. It just helps everything not contract down, because where that thing is, it's not going to stick down to itself. It's going to heal from the bottom up, because that's how secondary wound healing works, right? So you're protecting the top while the bottom comes out, and then it comes off. My pleasure. If you use vitamin E oil, vitamin E oil will dissolve it. So you can't use vitamin E oil if you use this. Yes? You're going to get less bleeding. So if you use it, so same. No vitamin E oil, that's the only thing. Unless it's getting crusty, and then use vitamin E oil, it'll come off. Yeah. So if you want it to come off, it's getting crusty, use vitamin E oil, it'll come right off. But if you have like those wounds that are a little bit bloody, or you're not so happy with it or whatever, a drop of periacral glue goes a long way. No, it'll actually be nice and soft. You're just using a drop. It's like over like the muscle layer. It's just a drop. If you put too much, yes, it'll come off. Try it on your own hand, okay? You put just a drop, kind of smooth it over, just so it's like smooth and continuous. If you have rough edges, you push too much, it's not going to work. Better not to do it. Start with the lips. Okay, if you're looking to do it, put it just a drop, see what happens. Kind of push it down. If it gets too thick and crusty, you put too much, or you don't want it to be wet. Good? All right. Okay, so let's talk about wound healing, all right? All wounds go through these stages of inflammation, granulation tissue, and wound contraction. And then from 2 to 6 months, we have a very important stage. It's called maturation and remodeling. Okay, and today we're going to talk about this phase of maturation and remodeling, which happens in all patients between 2 and 6 months. The most tight, when will it be the most contracted? 1 to 2 months. Okay, that's the most contracted. After that, it automatically loosens up. There are some things that we can do to accelerate the healing. All right, so the first few days you're dealing with inflammation. The inflammation brings granulation tissue through the first week. By about day 10, the granulation tissue starts to contract. When it contracts, you're getting type 3 collagen. Type 3 collagen pulls the wound in from all directions. Okay? Pulls the wound in from all directions. Tight. Then, from 2 to 6 months, the type 3, based on the movement that you're doing, changes to type 1, which is more linear. Okay? It's not pulling in from all directions. The type 3 collagen resorbs, and you get type 1 collagen, which is more stronger and finer and more elastic. Okay? So here we have a patient pre-op, 1 week post-op, 1 month. In 9 months, you can see from 1 to 9 months what an improvement we have just based on natural wound healing and remodeling. All right? In order for us to be successful in rating, hey, is it good to use sutures? Are you good to use periacral? What about vitamin E? What about serapeptase? What about wound stretching protocol? The first step is we need to have a good grading scale. Do you guys agree? Okay, so let's develop this grading scale together here, and your input will count, just like mid-tongue restriction, all right? So first of all, which stage of healing do we have here? Can you guess how long after surgery this case is? Exactly. This is 2 weeks post-op, okay? So if you want to get good, the first thing you want to do is learn to recognize which stage of wound healing you're at. You're at 2 weeks. This is the granulation into the contraction phase. Are you guys with me on this? All right? At this point, you can't really assess what's what, but what we say when we're evaluating them is saying, minimal granulation tissue or a lot of granulation tissue, and is the wound open or closed? Those are the things that you want to kind of evaluate for. If the wound is open still, it's going to delay the integration and maturation. If the wound is closed and small, you're going to have more advanced, quicker integration and maturation. Yes?
So if you're using sutures at 2 weeks, if the wound is still open, that's probably because the suture came out?
Maybe, yeah. Maybe. It's hard to say. Well, yeah, maybe the suture popped out, yeah. All right. How about, okay, here's another case, all right? Which time frame are we in now? Okay, that's pretty good. So this is, I think, closer to maybe like a couple months, I think, okay? Maybe 2 months, but 4 weeks is a good guess. The wound is closed. And then how's the mobility? Is it good, restricted, or still compensated? What do you guys think? Still compensated. You have that floor of mouth involvement, all right? The next thing we want to say is how thick is the wound? Is it 1 to 3 millimeters, 3 to 5, or more than 5 millimeters? 3 to 5 millimeters, okay? This is going to be helpful because you're not just saying, oh, it looks good. What do you guys put on your notes? The wound looks good? The wound looks bad? Like how, like who had good healing? I had good healing. Who had bad healing? I had bad healing. Like how do you even describe that, right? But this way, you're like, all right, the wound is 3 to 5 millimeters. There's some compensated mobility, okay? The next thing we're going to look at is the color, all right? Is it well integrated? Is it totally pink? We're going to go through some cases, so take some notes on the grading scale, or you also have the sheet there. Is the color, is it totally pink, well integrated? Is it integrating? I'll show you examples. Or is it distinct? It's like white, okay? If it's white, it's, a little delayed healing, okay? If it's pink, it's really good, well integrated healing. The smoothness, is it totally smooth, well integrated, slightly raised, or rough in texture? And the mobility. Those are the 5 different categories, okay? So this is 2 months post-op, fully healed, a little thick, a little contracted, and so we developed this grading scale, okay? Either look on the sheet or take some notes because we're going to go through it together, okay? This is the newest, way. So next year, I love the presentation this year on the CBCT. Keep that up. Next year, come and rate some tongue mobility. How are things healing based on different protocols? Hey, I tried, this kind of product or that kind of product. Look, I got a better Whims score. Wound Healing Integration and Maturation Scale. First of all, what do you guys think of the name, Whims? You guys like it? Okay, so because that's what we're trying to describe. It's about wound healing, it's about the integration, and it's about the maturation, and it kind of sounds good, right? Whims, but we went through many different variations. We were going to call it LFWHAS. Anyone like that one? Lingual frenulum wound healing assessment. It doesn't have a ring to it, okay? So we're calling it the Whims scale, all right? And there is going to be 3 categories, nice and simple, okay? 5 categories, 3 options. The first one is the thickness. You're eyeballing these. You're not taking out calipers and measuring it, okay? In the first one, you have 1 to 3 millimeters. You get 2 points. The middle option is, 3 to 5 millimeters. And the third option is 5 millimeters. So you get 2, 1, or 0 points. 10 out of 10 is incredible healing, okay? 0 is terrible healing, but it's not terrible because it changes. It matures. So it's in progress. It's delayed healing, okay? So where are you with the healing? Oh, you're advanced healing, you're delayed healing. The next one is the color discrepancy. Can you guys see on the first option how it's well integrated and matching? Yes? Can you see in the second that it's in progress? The pink, the melanocytes are coming in, right? The color's coming in. And the other one's just white. It's distinct color. This is going to be important because it's going to help you decide, are you a candidate for Kenalog or not? All right? If it's well matching, well integrated, all that, well, I don't know if you need to do anything. It looks good. If you're white, thick, means you have a lot of type 3 collagen, and you want to help it become more type 1 collagen, you have an indication to do something. Does that make sense? So, all right. Wound texture. Do you guys agree the first one is really smooth, right? The second one is slightly raised, and the third one is really rough and irregular. The next one is contraction. The first one is flexible, good when you put your finger in there. The second one has mild to moderate tension when you run your finger on it. And the last one is really tight and contracted. And then mobility, we already learned this one. Good mobility, compensated, or limited, okay? There's 5 categories. The best score is 10. 10 out of 10 means that you have good, you're all set, you're done. 0 means it's really bad. Okay? It's not really bad. It's early on in the healing, or there's complicated healing, or things like that. A 7 to 8 is going to be a good score. All right? Don't just put 10 out of 10. Most of them are going to be 7 out of 8. The tool has to be sensitive. So a 7, 8 is considered good. If you have all 10s, then you can't really measure anything. That's why the scale, 6, 7, 8 kind of range. If you're below 5, it's kind of really not good. You're going to need more attention, multiple rounds of Kenalog or OLAs, more attention. If you're a 7, 8, you could consider it, but you don't have to. If you're a 10, honestly, the patients don't get that much benefit from it. All right? So assess this wound based on the Whims scale. Are you guys with me? All right. So the first option is what? Thickness. Is this, raise your hand, is this 1 to 3 millimeters? Good. 3 to 5 or more than 5? Okay, so we see that there's some kind of debate, 1 to 3, 3 to 5, and that's fine, okay? There is going to be some variations in the scale, and that's okay. So, write down whatever score you did. If you said 1 to 3, you get 2 points. If you said 3 to 5, you get 1 point. If you said more than 5, you get 0 points. How is the color? Is it well matching, integrating, or distinct? Integrating, 1 point, okay? Is the texture smooth, slightly raised, or significantly irregular? Slightly raised, 1 point. Is the wound tense? Is it smooth, tense, mildly tense, or significantly restricted? Mildly tense, okay? And how's the mobility? Good mobility, compensated or restricted? Compensated, okay? So I gave this a 6 out of 10 healing, okay? So I give it a 6 out of 10. Now we're going to observe. In 2 months, maybe it's still a 6 out of 10, 7 out of 10. We give Kenalog. Oh, it's a 10 out of 10. That's how we're showing the Kenalog works. All right? I want you guys to try the Kenalog this year. I want you guys to try different stretching protocols and come back and say, hey, the Whims score was this at 2 months. Here it is at 4 months. Here's it at 6 months. And the timing matters, okay? Because doing nothing will also change these measurements. How about this? Is this fun for you guys? Is this helpful? Like to study the wounds, right? Because when you study it, you start to see things differently, you know? All right, so how thick is this wound? More than 5, it's pretty thick, right? It's pretty thick. How's the color? Okay, no color, right? It's like 0 color. All right, how's the smoothness? It's smooth, okay? How's the mobility? It's good, okay? Is there one that we missed? So, okay, so 3 to 5 millimeters, color's distinct, flat and smooth. So, you know, it's not bad overall. Even though it's a little bit white, it's not bad. If you just wait with time, it should improve. If you want to give it a little Kenalog, you can, but it's really not that bad. Whereas this one looks a little bit more significant, 5 out of 10, 6 out of 10. All right? This one, how's this one? How's the thickness? What score do you give? 2, okay. How's the color? 2. How's the smoothness? 2. How's the tension? 2. How's the mobility? 2. Okay, so you could say like a 9 out of 10 or 10 out of 10 healing. All right. So if this patient has a complaint, unlikely that Kenalog is really going to help you that much. You can try it; it's safe, but you know, don't pump it up so much. Does that make sense? All right. Let's take a look at this case. All right. That was a really tight tongue tie I did. You know, big wound. I used the sutures, periacral glue. Here he is at 2 months. I would say that's pretty good, okay? But instead of writing pretty good on my note, right? How's the wound healing? Wound looks pretty good, right? Do you guys do that? That's what I do, honestly, right? It looks bad, looks good. All right? Now we say, all right. All right, so who wants to take this one? Anyone want to take it? Go for it. 3 to 5 millimeters. Okay. Color? White. Texture? Yeah, slightly raised. And then flexible. I think I said 8 out of 10. Let's see this. Maybe a little off. So 8 out of 10, or you could say, if I said 1 to 3 millimeters, you say 3 to 5 would be a 7. I mean, it's not like 100% the scale between people. It's just a picture. It's on Zoom, so it's not the best, but kind of gives you a sense, all right? You want to ask, you know, why these things happened, all right? How does this wound look? Okay, it's thick, irregular, textured, limited mobility, like a 0, right? Probably. And so we revise it, and then it says 0 out of 10 healing, all right? And then this is how it heals after the first stage of release. It's better, but it's still not great, okay? It's still a little too thick, a little white, a little tense, restricted, so then we can consider her for a stage 2 or Kenalog. These patients would be very good for Kenalog, the ones with lower scores on the Whims scale. All right. Here's a case by Dr. Milton Gay-Velis that he contributed. I thought it was an interesting case. All right. So, you know, there's the frenulum band. All right. He did a really nice release. Okay. Based on what I would do now differently, I would put periacral glue between the sutures. All right. Because when there's so much tension on this wound and the wound is so big, this patient bit their tongue. The tongue swole up, and then as it swells up, what happens to the sutures? Pop, 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 pop. The periacral glue kind of helps it. The smaller you keep your wound, the less chances that the wound's going to separate. Does that make sense? All right, what are you going to do in this scenario? You're going to decide, is this stable or unstable hematoma? Stable means there's no bleeding. It's just a blood clot. Unstable means it's still bleeding. If it's stable, you watch it. If it's unstable, you got to clean it out, laser, periacral glue, things like that. Decide if you're going to resuture, probably not resuture. Leave it open to heal by secondary intention. So here it's healing, okay? Wide wound, how's the healing? Okay, so let's rate it. Not too bad, right? How's the healing? Not too bad, right? You guys want to rate this? All right, so what? more than 5 millimeters? Okay. Irregular, raised, textured, colors distinct. Okay. So now we're able to describe what we're seeing. Was that a fun experience? Yeah? We put a lot of work into it. Thanks to Laylee and Chad and Dr. Loria and Dr. Baxter and all of you guys for contributing. It's a work in progress, so come back and help us with the language. Say, hey, instead of this word here, put that word. We put the tool available to you guys. You guys have it. You guys excited to try it out? Okay, good. All right. So this introduces Kenalog 10. So Kenalog 10 is a steroid that affects wound healing. First of all, in terms of wound healing, it's a great paper here. It's open access. Download this article if you want to learn about the stage of wound healing. It's really, really, really good article, okay? It talks about the different phases, and basically, just to simplify it, you have type 3 collagen and type 1 collagen. Type 3 collagen pulls in all different ways. It's like a thick glue, like Velcro straps, grabbing the wound in. Type 1 is like a nice elastic silk, like a rubber band that's keeping the tongue together. At first, when the tongue is healing, you need that Velcro coming in from all ways, like tying it down. When it's better, just a little bit of like a little elastic, rubber band will do to keep the wound together. And that's how wound healing works. Depending on how you're moving the tongue, the environment, the inflammation, other things like that. Kenalog has been described in the fields of plastic surgery since like the 1960s, 1970s, all right? Dermatologists, cosmetic surgeons feel very comfortable extraoral. It has never been performed intraoral before we did it, okay? People were, who said someone was scared and then they did it? Who was that who came up to me? Who did I walk in with this morning? Okay, what did you say? Dr. Robles? So you had like a little lip issue or mouth issue, and the dermatologist felt comfortable injecting on the outside, but didn't feel comfortable on the inside because it's never been described, okay? So just telling you about like the research process and what we do in our clinics and the risks that we take, right? Because you can have complications, and I did have a complication. It was a really bad complication, all right? But I just want you guys to know like what we do, the pain of it, in order to succeed. And so, even though it was described, I decided to try it for the tongue. And I used the same syringe the plastic surgeons use. It's like a little Botox syringe, 1 cc tuberculin syringe, okay? This is what it is. And the way that you get it is either Kenalog 10, which is previously diluted, or Kenalog 40, and then diluted down, okay? If you get Kenalog 40, then you put 1 parts of this to 3 parts of saline, all right? So basically, you could like get the whole Kenalog 40. I think it comes like in a little syringe of like 1, 2, or 3 mLs. For every 1 ml of the product, you put 3 mLs of saline or buffer or whatever, and now you have Kenalog 10. Does that make sense? Kenalog 40 is less expensive than Kenalog 10 and easier to get. I like Kenalog 10 because it's clean, it's ready to go, it's like ready, like it's all good. Kenalog 10 like this costs about $20. You can use it 4 times. You can use it 4 or 5 times. The Kenalog 40, same cost, you could use it like 20 times or something, okay? What else I want to say? You want to shake it up, okay? You don't have to refrigerate it. You keep it out. If you refrigerate it, it precipitates, so you want it to be warm, all right? You want to shake it up. If it precipitates, then it doesn't look so good. So just to tell you about the research protocol, the first patient we do, all right, we tell them straight up, I have never done this before. You are the first patient doing this. These are my options. We can either do this, this, or this. I'm really interested in trying this. I'm very hopeful, but newspaper test, it's investigational. We don't know. But the patients who are coming to you are coming because you're on the forefront of research, and you'll find the patients that are open to it. Meanwhile, don't pretend to your patients that you have a lot of experience when you don't. If you don't have experience, you say you don't, they'll still do the treatment with you, believe me, if you're transparent about it. Say, hey, we're on the forefront, I just got back from a conference, here's the protocol, here's what it is, let's give it a shot. I have mentors to support me if I have an issue. Okay, so here's the patient, here's how it healed at 2 months, all right? And here it is 1 month after Kenalog. Do you guys see that? That's pretty good, all right? Can I publish a paper and say, okay, the patient presented with all right healing, and then it went to Very good. No, so we have to come with a grading scale. So we have these pictures, and the grading scale that we're using is the Whims scale. And based on the Whims scale, you can see it's maybe 3 to 5 millimeters thick, textured, tense, restricted mobility, maybe like a 5 out of 10. I marked it as a 3 out of 10, okay? And then afterwards is 10 out of 10. Are you guys with me on that? Okay. And so that's how we're demonstrating that the wound healing is improved. You can see that it's improved, but having like an objective way of assessing it that everyone agrees on is superior. Here's another case, all right? I won't spend too much time on the grading scale, but I scored it as a 4 out of 10 and then an 8 out of 10. And here is a patient here. Hello, my friend. Welcome back. It's great to see you.
Yeah. Hey,
We're here to follow up after the Kenalog injection that we did for you. I think it was maybe, what, 2 to 4 weeks ago? Is that right?
3 weeks ago, right?
3 weeks ago. 3 weeks ago. How is it going?
Yeah, fantastic. It's just right after that, it was still feeling a little tight. And then like over time in the last 3 weeks, I don't feel any tightness or pain when I try to touch the spot and open the mouth as wide as I can.
Amazing. So you have much improved range of motion and improvement, and the tightness all went away. Amazing. Did you have any complications or side effects from it?
No, nothing. It's just, you didn't even.
Great. On a scale of 1 to 10,
when you injected.
on a scale of 1 to 10, how satisfied would you be with the injection? And would you 10 out of 10? And would you recommend it to others?
10 out of 10, yes.
Amazing.
Think
Amazing.
about it.
So good. Did you do your
should just
myofunctional
do it
therapy
as a
exercise?
standard practice.
What's that?
You should do it as standard practice.
Do it as standard practice. Amazing. Did you do anything else like myofunctional therapy or stretches? What else did you do?
After the surgery, I did myofunctional therapy on a weekly basis till the Kenalog injection, right? And then after the Kenalog injection, I didn't actually do the exercises at all.
Okay. So he's being honest about it. That's probably didn't do it after the therapy either, after the procedure either, which is why he got tight. But it's all good. And so you don't have to do any therapy. If you want to do it, you can, but you don't have to do the therapy. Yes. You can give it once the wound is closed, okay? Because at first you need the type 3 collagen, and so if it's open, you're not going to get type 3 collagen. You're going to have a bigger wound. So you want to wait for sure until it's closed. You don't do it the same time as surgery. You get delayed wound healing. Once it's closed, you're in the 1 to 2 month. You're like still contracting. Maybe you still need the type 3, okay? Because if you didn't have it, maybe the wound will open again on you. So do you want to risk it at 1 month, or do you want to wait till 2 months where you're out of that contraction phase and you're in the mattress remodeling phase? So 2 months for sure, 1 month if it's like, it's closed. Is that helpful? Yes. Yes. You do it once, maybe twice. Yeah. 1 to 2 months. Yeah. It works for about 2 or 3 weeks, and then it's out. Okay. More pictures, just for the sake of time. Patients love it. We try a lot of different things, and some things hit, some things don't. We're transparent about it. You draw it up. I'm not gonna, I'll kind of go quickly on this. We show the floor of mouth hold improves after this. Okay, that's a good thing. Let me just show you how to do it.
Stick your tongue out of your mouth. Excellent, excellent. This is a Kenalog 10. We've already put Carlicina on there.
Right, so we put topical first. You can see it's thick, regular, 3 to 5 millimeters. You go directly into the wound, directly into the scar tissue, and you open it up. Okay, it's kind of like micro needling. The very action of going in there breaks up some of the scar tissue, and it releases it. So you're doing few drops.
Halfway there, okay?
You see how it's spilling a little bit? You want to wipe that away. You don't want to go in there and spill a bunch into the mouth. And that's like a novice move. You're going in there, and then you inject, and then it starts to spill out, and then they start to swallow it. Those patients will get throat pain. If you give too much too quickly, or when it's open, you can get candida fungal infection, esophagitis, and it's pretty not fun. Okay.
Right.
So you guys saw that.
For me?
Show you one more, just for the sake of time. Okay.
Good.
You see how thick that wound is directly into the scar tissue? Okay? Not into the muscle. You're trying to break up the scar tissue, right? Any questions about it? Like 2 months. Yeah. Yes. Great. I feel safe doing up to 1 cc or 10 milligrams in adults. And I have at 0.3 easily on a child. Okay. I have done up to 0.7 on a baby. It just depends on how much scar tissue you have. Okay. So if you have like a lot of scar tissue, you can go more. But I don't know if I feel comfortable too much there. Yes. What's that? Uh-huh. You'd have to do it all the time, right? Like multiple, just one administration or multiple administrations? Like multiple times? That introduces more trauma, stress, contraction. This is a one-time deal. So it's a one-time, boom, boom, done, like you're set. You don't need to do anything else. So yeah, you could try the topical cream. I think someone said that they used it. But every day, and then there's for sure swallowing it. Okay, and then Candida risk, I think, goes up. I don't know. Over time, these things can resolve. We're taking pictures and measurements. Patients are really happy. Most patients experience improvements. Some don't, okay? Some people experience improvement right away. Some it takes about 3 weeks, okay? But there are some patients who don't improve, and we're using the Whims scale to identify the patients that may improve the most. Patients experience less tightness, less scar tissue, greater range of motion, but there are complications, all right? And the major complication is that of fungal infections. There was a patient who had probably 4 tongue tie lists before she came and saw me. I said, let me do Kenalog before I even start. All right, so I did Kenalog, and then I did more Kenalog and more, and I probably put like 1.5 milligrams. And then when I released it, I put some, and then like afterwards I put some and put a lot more. Anyways, she got really bad thrush, all right? Painful swallow that lasted like a couple months. So there is a rate limiting factor, all right? Being transparent with you guys, telling you that it's good, but also like be careful, don't do too much. It's good to kind of test the boundaries of things. If this has been reported in monkeys, we want to consent them for the possibility of it. So you basically don't want to do it if you're worried it's going to open, or if they're like immunosuppressed, not healthy, they already get thrush, they have like fungus in other parts of their body. If you do get it, what you're going to treat it with is clotrimazole troches. It's 10 milligrams. It's a little antifungal that they suck on, and you do it like 5 times a day for a couple weeks, and that should kick the infection. Okay. Any questions about that? Finally, there's a serapeptase protocol. Yes. Yes. So if we do a tongue tie release and it's like a 3-month-old, 6-month-old, whatever it is, I didn't like the way it healed. It looks thick. Okay. Mom's still complaining. You see improvements. Okay. In addition to that, we are also doing Oralase, which is a 1064 nanometer wavelength treatment that also really helps. Okay, so I really think there's like 2 categories of patients. I do the Kenalog on some people and they're really happy, but then some people do Kenalog and it doesn't hit. They feel tense everywhere. These are usually the ones that on the Whims scale, it doesn't look so bad. On those patients, when they're feeling tight everywhere, I send them for the Oralase procedure by my wife, and these people have like fascia releases, and it's like incredible. It's like a 5-minute little laser procedure that opens up. So I feel like it's like a different kind of a indication. Any questions, comments on that? Good. All right. Serapeptase works by eating away at the tissue. All right. It eats away at the granulation tissue. Who here uses it? Okay. Good results. So-so results. So-so. So-so. The problem. Yes. Good results with serapeptase. So how do you use it? Mom scrubs it in there. It dissolves away the granulation tissue, huh? Okay, so the way it works is you have all this type 3 collagen, you have too much type 3 collagen in there, right? Too much granulation tissue. So it eats it away. Like you spray it on there, and so you have less type 3 collagen. Is the wound healing longer or shorter? Probably longer wound healing, huh? Okay, so it's more flexible, but it delays the wound healing a little bit. I don't personally use it in my clinic. The reason is newspaper tests, okay? For the Kenalog, it's been used since 1970 in plastic surgery and dermatology, and I'm using the same dosage indications as you would in plastic dermatology. That passes for me. This product specifically says don't open it, and it's never been used on babies. It's an anti-inflammatory. So it's a little bit rough for us to experiment on it, although you do get the results like you're saying. It's just a little bit like harder to like implement in that context of high scrutiny. Does that make sense? You tried it yourself, what'd you think? Okay. Yeah, it worked. Amazing. It just ate away the granulation tissue and didn't cause any bleeding or complications like that? 5 weeks later. Amazing, okay? So something to look into if you want to do a presentation on it next year. I'm interested to kind of hear what people have to say. That's where the research comes. Do the Whims scale, compare this to that, you know? Let's see. So we have Kenalog cream, we have serapeptase, we have Oralase, we have anything else people use? People like? Vitamin E oil. Okay, so whatever you like, you know, try it, measure it, kind of see, but also kind of know where you stand. So if you're going to use this, you say it's an off-label indication for this product. It's an off-label indication. It's not FDA approved for this. The Kenalog is FDA approved for scar tissue. That's the difference. All right, so functional tongue space analysis. We're doing the LPS palatal overflow. We've described this in the past. Who here finds this like a helpful tool? Okay, good. Who here finds it helpful to look for scalloping to decide on tongue space issues? The Friedman tongue position, okay? And so the final one that we want to talk about is the LPS palatal flutter sign. This is something that's often confused, so let me take a minute and spend a second on it. Basically, what you're going to do for this assessment is you're going to have the patient open up their mouth and make the snoring sound. Try it with me. You're making the palate flutter. Now you're going to close your mouth, put your tongue up to the roof of the mouth, and then try to snore. Try to make that palatal flutter. If you can't do it, that's a positive sign that myofunctional, ENT, things like that are going to help your condition. Soft palate are going to help. It's a positive indication. If you can snore, mouth open, mouth closed, no matter what, you can make like that deep, deep sound, that's a tongue space issue. It's negative for what we're going to offer, okay? Even for soft palate, if you can make that snoring sound with mouth open, but not mouth closed, you have a good chance of getting it, okay? If you can make it with your mouth closed, you might improve it, but they're for sure still going to snore afterwards. Okay? For sure going to snore afterwards. So that's how you're going to use that one, all right? Who here has used the palatal flutter? You guys find it helpful to prognosticate? Yeah? You guys like it? Okay. And so, you know, the palatal flutter comes from the Pang-Rotenberg sign, which has been validated in ENT. And we've been working on this study for a few years now. So we are proud to introduce, you guys know about the Ferris 6? We now have the Ferris 6 plus 4 for adults. All right, who's excited about this one? All right. And so the difference in kids and adults is in kids, if you have a myofunctional issue, you're going to treat it. You're going to treat the soft tissue, okay? The tonsils, the myo, the tongue tie, you're going to do everything. In adults, you really have to weigh the tongue space issues. You really have to like think about that more. And so the plus 4 are directed at managing, is it more on the first side, like an ENT tongue tie issue, or is it more of a tongue space issue, depending on how many scores you get on this and the CBCT. So, you know, give it a shot. Let us know what you think. Anyone already seen this or implemented it? You guys like it? You guys hopeful for it? Okay, very, very, very good. If you want a copy of the instrument, see our team and they'll make sure to get it to you. So we have the original Ferris 6, but then we have Friedman tongue position, LPS palatal overflow, tongue scalloping, and our palatal.
Make the snoring sound?
Is she positive or negative?
Good. Now push your tongue up, make the suction hold. Now try to do it.
I can't.
Okay, so is she positive or negative for the indicator? Positive. She can't do it with her tongue is up. She can't do it with her tongue is down. That's more favorable, all right? Here's her CT scan. Oof, 29 millimeters, all right? So what are you going to do first? You're going to do tongue tie first, or you're going to tongue space first for her? Is this good mobility, compensated, or restricted? It's compensated if that, right? So are you going to tongue tie release on her? Tongue space, okay? The tongue space, you see it based on the Ferris 6 plus 4, okay? She has 3 out of 4 factors. Friedman tongue position is 4. She has severe palatal overflow. She has tongue scalloping. She doesn't have the palatal flutter, so she has 3 out of 4 on that. She has 29 millimeters. But her posterior airway space is wide, Dr. Zaghi, 1.6. What a wide airway. Well, that measurement isn't the measurement you want to look for. What's the measurement you want to look for? The NBC3. All right? And her NBC3 is 125. Do you guys know about this? Nasion Bayesian C3. So when you're assessing CT scans, the finding is the posture. That is the finding. If you put them in a headrest, chin rest, stabilize their posture, you can't measure changes in posture. When you do an intervention, the outcome is better posture first, then airway size. The airway size is dynamic, as is the posture. But what we care more for are those posture changes. And the posture changes come from the palate expansion, but also from body work, strengthening, and things like that. Does that make sense? Because when your head is forward, this is what's causing your TMJ issues, back pain, neck pain, shoulder pain. You want to get the head back. The reduced airway size is a sign of postural compensations and things like that. Questions, comments? So it's not to say that CBCT is not a valid measure. The first thing you want to look for is the NBC3, and the second thing you want to look for is the airway measurements, okay? And you don't want to isolate the NBC3 because they'll do funny things that'll alter their airway because breathing is first. All right, here are the widths for the adults and pediatrics. We're short on time, so you have the references so you can see it. For kids, we go 24 plus age based on the Bose index, graciously offered to us by Dr. Kevin Boyd. Again, for the posterior airway space, you can see the restriction retromaxillary, retropalatal, retrolingual, and head posture makes a big difference. This is the same patient, one with the head slightly down, one with the head slightly up. In the first example is 6.3. Examples like 1.3, so twice as big. Again, when the head is down, the airway closes. When the head is up, all right, the airway opens up. Posture is integral to tongue posture. We now published open access in the Journal of Oral Maxillofacial Surgery, the Nasion Bayesian C3 angle. A 5-degree change changes the airway by 25%. A 10-degree change changes it by 80%. 15 degrees is 1.5. All right, so if you have a patient like this who is 15 degrees more than average, it's like 150% compensated, okay? It's 1.5 times. So after you treat her with palate expansion, her airway will not get bigger. It'll probably get smaller. This patient, you do palate expander, her airway will get smaller. What now? Okay, because she doesn't have to try as hard. Her head will go back. Her NBC3 will go from 125 to 110, and her airway will go from 1.6 to 1.2. Have you guys noticed that yourselves too in your practices? Anyone else notice that? Okay, all right. So keep that in mind. Let's look at the posture. How many physical therapists do we have in the group? Body workers, body professionals? More of you guys, okay? Neil's made me a believer. Thank this guy, yeah. When you experience it yourself, okay, it can be really, really incredible. All right. So any other questions about tongue space? Just want to make sure we addressed all that, and then we'll hit soft palate. Here's the protocol. You don't want to be swallowing during it. Again, I wish I had more time to spend with you guys. We have about half hour left. Questions on the protocol? You guys using this protocol? What happens if you use a chin rest? Where does the tongue go? It goes up. You can't evaluate tongue position anymore. Even chin rest, you affect the tongue posture. Okay? This is one patient who's swallowing. Here he is like this. If you push this up, it'll probably look something like this, okay? Anytime you have the chin rest, the tongue is getting pushed up. You don't want to use bite registrations. I'm trying to give you guys as much as I can in limited time, okay? Let's now talk about, okay, let's see this case, all right? 74-year-old male. All right, he has the bite registration in there, okay? His tongue is down, they use a chin rest, all good. You don't have to repeat the scan, you can see a lot here. He's 74 years old, has severe sleep apnea, unrefreshing sleep, RDI of 12.6, worse with CPAP. Does anyone want to offer him tongue tie surgery? Doesn't even matter what the tongue tie looks like, I'm telling you. If the situation looks like this, tongue tie is probably not going to help. You can start myofunctional therapy first, He's not that healthy, but you still want to help him. There's a target here where you can help this guy. Do you guys see it? What's the target? The soft palate. How do you know? It's elongated below the occlusal surface. Are you guys seeing that? So for this patient, I wouldn't mess. I mean, I think he had a little dementia too and things like that. For this patient, you're not going to mess around with therapy. Like, no offense to the therapist, okay? So what I offer him is Excite OSA. It's a device that goes inside the mouth. It's neuromuscular education. It goes in there and it stimulates the tongue for you. Works on people who've had strokes. It works really low tone as an adjunct to myofunctional therapy. Really, really, really good, okay? This has been shown to really help with sleep apnea. Any tongue weakness, it will help. So to this patient, I'm gonna give him an Excite OSA. And hey, we have this new intervention, the soft palate elongation. It's not gonna cure all your issues, but it is gonna reduce that soft palate length, all right? So this is the non-ablative CO2 tissue remodeling. And this procedure is not a snoring treatment. It's a treatment for soft palate elongation. Does that make sense? Okay. Tongue tie release is a treatment for ankyloglossia. It's not a treatment for sleep apnea. Okay. So you got to be like kind of specific in terms of what you're going to do. Questions, comments? Okay. So, but it works really well. I want to congratulate Dr. Sophia Katz and Dr. Huffman who listened to the presentation yesterday. Okay. Amazing, amazing. Okay. So good. Putting it out there, sharing your experience, whether it's successful or not, informs us. So I did hear that some of the results were equivocal, okay? Sometimes the soft palate went up, sometimes it went down, like what's going on? And that's very helpful feedback because whatever we do has to be reproducible. First of all, shout out to Dr. Katz's son. Okay, I would love to get a copy of this.
The laser on the left is an ablative laser. The laser on the right is a non-ablative laser. The non-ablative laser just makes the cells go closer together. The ablative laser destroys the cells by vaporizing them.
Okay, amazing. Yeah, I'm going to ask you for the whole video, but that was like an amazing explanation, okay? And the reason this becomes relevant is, will this non-ablative laser work for tonsils? All right, let's think about that. I'll tell you my personal experience, but we'll also get it from the physiology. This laser tightens tissue. It doesn't remove tissue. Is it going to remove the tonsil tissue? No. It's going to tighten it. What happens when you tighten the tonsil tissue? It gets more compacted in there. The crypts and valleys are now smaller. The food and bacteria are more trapped. Okay? It doesn't work for tonsils, in my experience. I understand that the Photona way of doing it works for tonsils. It's all good. If you guys want to try it on the tonsils, go ahead. I'm just telling you, I really, really tried hard on this and I couldn't get it to work for the tonsils. It works really well for the soft palate. Really well. 2 minutes, predictable, reliable, we got it down. 2 different settings. I prefer this setting, all right? This is if they're really slow, if you want to be slower. Here are my frenectomy settings, the ablative laser settings. Here's what the procedure technically looks like. This is the kind of hand speed that you need. Okay, very, very good. So basically you make 1 pass horizontal, vertical, complete the treatment, and I probably do it 3 times total, okay? How do we set it up? I give them 4%. I know you had an amazing presentation on the different kinds of topicals that you can put back there, amazing. The way that I'm doing it, nice and easy, 4% lidocaine. I have them gargle it. I fill up about 30 mLs of it. And 15 mLs, they gargle for like 15 to 30 seconds. Have them do it for 30 seconds, and then spit it out. Wait, don't wash out. Do it 1 more time. Okay, they'll be numb. They're going to be good and numb at that point. You don't want to use benzocaine. If you use benzocaine like the hurricane spray and all that, which is what you would think to use, right? How long of a spray is recommended? Half a second. That's it. If you're that's methemoglobinemia, all right? So this can be overdone, but this works, legit works, okay? So when I was doing the tonsils, I was using some hurricane spray because the tonsils, it does hurt when you get in there, all right? So these are the settings. Peter gave you guys these. You have the slides. Here's what it looks like, okay? You're going back and forth along the soft palate, and you're going for that white chocolate chip look, all right? See the white little dots, dot, 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 dot. You're gonna go until you see like a little bit of white. If it's still pink, maybe you didn't get like, that's not the way I'm doing it. Maybe that's the way you guys are doing it. Are you guys doing to white chocolate chip or to pink? White chocolate chip, how? White chocolate chip, okay? So you don't want it to be black. Black means you ablated it. This is non-ablative. So you want it to be just a little white, just so you got under the mucosa. Are you guys with me? Does that make sense? All right. And the other key, and then, you know, this is this patient we're about to do, okay? The other key finding, the real like secret to the success, the secret sauce, is not only doing the anterior soft palate. You guys see my mouse here? But right here, this is the money. You guys see this? The posterior palate. That's the real money that pulls it forward. In fact, I think that's more important than up here. So go a little bit up here. All right, you're good. But as long as you miss this, it's still going to look low on your CT scan. And you want to get the uvula too, because that's still going to be low. Are you guys with me? Is that interesting? Okay. It's right here. White chocolate chip pulls everything forward. You can see it. Patient breathes. It's like, it's good. Okay. Let me show you. All right. Hi, everyone. We are here with Sven, who's going to allow us to learn about the new technique for the soft palate laser application. All right. So we have our laser set up here. Okay, we're gonna go to Zaghi MD laser educational resources. This video is on YouTube. It's on my website. Okay, so if you want to show your patients this, we have a web page. Soft palate setting. All right, good. Take a look inside his mouth. All right, go ahead and open up for me. Good. Say Good. Go ahead and make the snoring sound. Good. One more time. You can see that nice vibration in the soft palate. That nice palatal flutter. One more time. Go ahead. Good. Let's get a little bit closer there. One more time. Good. Again. Great. Love it. Okay. So now we're going to go ahead with the treatment. Let's get the laser ready. Go ahead and open up for me. Very good. All right, so we're going to get at different targets, okay? The first one's going to be the soft palate. Now we're going to the anterior tonsillar pillar. That's right there. Now we're going to the posterior tonsillar pillar, okay? Close and swallow. Open up your mouth. Say, ah. Now I'm aiming for the back there, okay? Swallow. Good. Open. So this is the back area here. That's the posterior tonsillar pillar. See that there? We're going to tighten up the back. Very, very good. Okay, you can already see a little bit of lift there to the palate. Now the opposite side. Say, Very, very good. You can see it's turning a little bit white where we're treating it. Very, very good. Next, we're going to go to the uvula. Close and swallow. Open. Good. Okay, we're going to do the uvula. Up and down. Okay, and then side to side. Little lattice shape. And some ellipses. Good. Now we're going to go to the, if you're an ENT or if you're adventurous, I'm going to show you how to do the tonsils here. So no tonsil on that side, okay? On this side, this tonsil looks a little bit enlarged. Say ah. Say ah. Ah again. Okay, just getting the tonsil there.
Really, really good. Close and swallow. Open. Say ah. A little bit of tonsil there. Say ah again.
Any questions or comments? Good. What's that?
And that's the protocol. Go ahead and
Not intentionally. Yeah, it'll work better if it's a little dry.
Yeah. How about?
Yes.
Try again.
Mixed.
Very, very good. That's be our first
Mixed results.
session. We don't
It'll,
wanna overdo
if you're
it.
having tonsil stones, it'll close up the crypt.
Okay.
Thank you so much.
But now you closed up the crypt.
It was very easy.
You know? Yeah. All right. So very, very good. Amazing case by Dr. Sutter. Is he in the room today? Okay. I really enjoyed seeing this after the seminar. Putting into action, great result. Okay, you can see the lifting. Again, the pictures doesn't really tell you the whole story. The CT scan is preferable for assessing that. How to measure the soft palate length. Here's another case where the soft palate got bigger. Again, the pictures, it could be like optical illusion. So here's an amazing case by Dr. Merchant, and we can see that the soft palate is really long. And then it's shorter, right? So it legitimately, I believe, if you do the right protocol, right patient, elongated soft palate, will reduce it. And I think that this is the main outcome I'm looking for. Did the soft palate decrease? The secondary issues of snoring, breathing, and things like that are secondary to the shrinking of the soft palate. We're looking to do more studies on this. If there's anyone who's really, I have a lot of different interests, all right? This is we think we got it figured out. But it's not like a dying, burning interest of mine, to be honest with you, because there are other people who are doing it. This is already FDA approved for this indication, so no one's asking where's the research for this. Dr. Schiffman's pushing the research on that front. So it's not like a big need for it, other than to show that perhaps the CO2 is more effective at doing it than the Photona. But we have a lot of things on our plate. If there's someone who wants to push this research, if you guys want to push it, I think Hal, Huffman, and Katz, I would love to get a little group. Anyone else interested in being a little cohort and taking over the project? Dr. Merchant? Anyone else? Okay. Yeah, email Laylee. Thanks, Laylee. If you're interested, we'll get a little cohort together. I'll set up the design for you. It's not like super interesting. It works, but it's like self-evident. It's like obvious that it works. So I'm more interested in like the debate and like all the juicy stuff. Does that make sense? Any questions on the soft palate? Anything guys you guys wonder? Yes. Long lasting. I get it like 1 or 2. Your husband did it, right? No, hasn't done it yet. Got it. It's long lasting. I'll do it once. I don't want to overdo it. Maybe have him come back another time. It lasts. Like a year at least, maybe 2. Yeah. Yes. Can it come back? It can be overdone. So if you overdo it, you can get issues and problems. I described a case last year where it just went too high. If it goes too high, the tongue base won't reach the roof of the mouth. You have difficulty swallowing. Dr. Schmidt here? So Dr. Schmidt had it done. He had like a tongue tie issue, like myofunctional issues. To swallow, you got to get that mid-tongue up to touch the palate. If there's no palate, it affects your voice. And then the mucus, as it's coming down post-nasal drip, sits there. You can't swallow as much. You get more redness in the back of the throat. So you're not trying to destroy the soft palate. You need to cover it there to protect the back of the throat. So you want to do it up to the occlusal surface, but you don't want to like remove it. Other questions? Yes. Mainly adults. Yeah. I don't know the answer to that question. Yeah, I'm not involved in that, to be honest with you. Yeah. Other questions? So what questions do you guys have, like research questions about? Is this like, I'm interested to know. I think we got it figured out, but are there any research questions on this, or you guys convinced that it shrinks it? Yeah. The tongue, like to shrink the sides of the tongue, it hurts a little bit when you do it with the CO2. And I tried it a little bit on the sides of the tongue. I don't really enjoy doing it. I like to do something like Kenalog and like, boom, wow, thank you, doctor. Or like this, like it really worked. They have you do it underneath the tongue. They're tightening the fascia tissue there. It's kind of like opposite what we're trying to do to loosen up the tissue with things like Orlays, I would defer to them, okay? They have some great protocols going on. I know this, in terms of, photobiomodulation, the light scalpel is one way of doing things, non-ablative laser. There is the 1064 nanometer wavelength. There is the 800 nanometer wavelength. There's a laser for everything. I'm not sure the CO2 is the right treatment for those indications. People say that the photona can shrink tonsils and decrease inflammation and improve wound healing. That's all good. Try it in the nose, all good. I don't think in my hands I'm getting these results with the CO2. Okay? But I'm getting really good results for the soft palate. So every tool has its indication. The indication for the CO2 non-ablative is soft palate. Also, if you have any bleeding anywhere. If you have bleeding in the nose or bleeding in the side of the throat or bleeding from a tooth or ulcers, works really nice. Works really nice. So those are the indications I'm using it for. Thank you. All right. Dr. Stewart had a case. Okay, I would have wanted to get him up, but I'm a little short on time. Basically showing right, left. Okay, he did one side and not the other and demonstrated on a couple patients that when you do it, it legitimately lifts it up. Amazing how, right? Wow. We have these case studies. I'm not sure it makes sense to do too much more research because we expect it and we know it to work. And he did it on a couple patients. He did one more patient where he did one side and not the other. And when you do one side and not the other, the soft palate, lifts up asymmetrically. So it's been shown. Again, I just want to know, are there any research questions about this? Is there anything you wonder? Okay. We'll still do the study on the soft palate elongation, okay, if you guys are up for it. It could be useful. We'll get Peter. I know Peter's interested in it. But I think we got it squared away. All right? Continue, but nevertheless, you want to continue to observe and improve. How do we get it better and more effective? Here's Hal's case showing that the sleep apnea improved. This is fantastic research. We're so proud. All right. The final thing I want to touch on before I bring up Layli and Chad to talk about how we're going to push the field forward is our research on lip ties. And so last year I introduced some of this research. It's now being considered for Journal of Pediatric Dentistry. And so this is a major accomplishment to kind of discuss lip ties more formally in literature. This picture will be published in the journal. And it's showing you, what is it? What is a maxillofacial frenum? Where is the anatomy? A lot of pediatricians don't know these things. Practitioners don't know these things. So we hope these images are helpful. The attachments can be mucosal, gingival, papillary, or papillary penetrating. All babies are born, most of them, with papillary and papillary penetrating attachments that by ages 3 to 6 naturally remodels. All babies have class 3 and 4. So if you're doing a lot of lips, you may be overdiagnosing them. Not to say it doesn't help if they're having issues, but it's probably helping because the lower jaw is recessed, they have oral incompetence, and releasing the lip is helping the oral incompetence. So I'm not saying don't do it. If you're getting good results with it, go ahead, but it's not a problem because it naturally regresses over time, whereas the lower lip, it does not, all right? So again, even things like tension, I feel tension in the lip. Well, there's supposed to be some tension, all right? All babies have tension in the lip, 92%, okay? Up until age 3 to 6, and then it gets less and less. There is a possibility that above age 6 to 12 or 3 to 12, it's tearing, and we're looking at our affiliates at looking at how often does it tear versus naturally recede. Let me share with you the case of my son. My son had a very low attachment at 2.5 years old, difficulty brushing his teeth in that area. We didn't do the lip tie release at the time of the tongue tie release. It was really difficult to brush his teeth there. A year later, we see apical migration of the attachment going up naturally, much easier to treat. So the truth of the matter is, between ages 3 and 6, there's a chance it can resolve on its own. Don't scare patients into doing lip tie releases. I know you're seeing good results. It's all good. Continue doing it if you want, but also consider that the reason that you're getting the good results is the fact that the problem is not the upper lip, it's the jaw is back, okay? And when you release the upper lip, you're helping compensate for that. But the problem is the jaw is back. So if you're going to do lip tie release to help them because you're so good at it and things like that, well, are you going to miss the underlying issue, which is the bodywork, physical therapy, jaw growth? If you really want to help the patient, you'll first put them through the bodywork craniosacral therapy to get that jaw growth, if you really want to help them. If you're just trying to do a procedure and you miss that, then you're just trying to do a procedure. Don't kid yourself. All right? Is that fair? Yeah. All right, so these procedures do help, okay? They have tension, difficulty with lip seal, they have vertical growth because of mouth breathing and other issues. This child, his problem is not lip tie, all right? His problem is vertical jaw growth because of mouth breathing, tongue, myofunctional issues. But he's having difficulty getting his lips together. I can release that tissue, lengthen his lower lip, and improve oral competence, improve that seal. Sandra Kahn is doing some amazing work on lip seal with her uplocker system to get the lips together. If you don't get the lips together, you don't get that suction. Okay? So the lips have to come together. If the upper jaw is going too down, lower jaw is too back, lip tie releases can help, even though it's not like a problematic lip tie. All right? This girl, we do these lip tie releases. It has cosmetic benefits for sure. People like it. We offer the treatment, but we don't scare people into it, all right? Really good aesthetic results, okay? But it's really it's like a lip lowering, lip lengthening procedure. So the last little bit that I'll talk to you guys about is buccal ties, okay? Buccal ties, we just came up with this paper, kind of assessing what different people think. The classification system can be mucosal, gingival, or alveolar. And we described what it is. Who here has seen this paper? Yes, Dr. Baxter maybe talked about it a little bit as well. It can cause various issues. So the benefit of this paper is that it's defining something. It's interesting to see the wide variation in different providers, okay? Different people are doing different things. There's no real consensus. Highly experienced providers tend to treat it more, people who've been doing this for a long time, whereas more novice providers don't see as much into the buccal ties. The way that you want to assess it is based on palpation and symptoms. Most people agree on that. Just based on symptoms is not a valid way of assessing it, okay? You have to feel and have symptoms. Many people rely on lactation consultants, body professionals, or feeding therapists. I think that's a good thing, okay? Because if you have these buccal ties, it could be because of symmetries and strains in other parts of the body. If you do it, most people will do it on both sides, which I think is an interesting thing. 5 to 10% of infants may have buccal ties. Some people are diagnosing it like never. Some people are diagnosing it in over 50% of tongue-tied patients. All right? Some people say the incidence is less than 5%. Some people say 80% of you have tongue ties. So that's like we're all over the place on that, Which is it? Is it 5% or is it 80%? To the extent of buccal ties, if it's tense, if it's causing a problem, you're going to advocate for, first body work, physical therapy, all that. And then bilateral release, if you do asymmetric release, you can get, scar tissue up more on one side than the other. When I do these for adult patients, I go from the midline. So I do a lip tie release, and I buckle through. I dissect through to get all the attachments. It can help. It can loosen up the tissue. People respond well to it, but we don't want to scare patients into this again. It's super elective, investigational. All right, let me give you a pop quiz on a diagnosis, and then we'll get Laylee and Chad if you want to get your computer up. What's the assessment here? What's the problem here? Yep, lip lickers dermatitis. This is an individual who is licking their lips, probably because they have open mouth posture, nasal obstruction, and when the air is going through, it's drying out the lips. What's the diagnosis in this case? You guys see the problem? Something that's becoming, what's that? Let's say it again. So this is actually associated with chronic mouth tape. Yeah, people like mouth tape, hostage tape, Somnifix, all those serious tapes. Over time, because I'm interested in saying that everything has a risk. And when you talk to your patient, talk about the benefits, talk about the risks. So a risk of long-term mouth tape use is adhesive-related traction alopecia. So every day you're ripping. Just something to be aware of, not trying to scare you guys too much, all right? So did you guys have fun? Yeah. All right, very, very good. Hope you guys learned some stuff. I got it in there in 2.5 hours, okay? If you guys are interested to really go in depth on all these different topics, we'd love to see you at the Breathe course in person. We also do live stream of the Breathe course now. We go through everyone's cases, floor of mouth holds, CT scans, really dive deep. And more than anything, I want you guys all to recognize that we need more research. Who's here? with me on that concept, that we need to keep pushing the research forward, okay? We need to be more resilient because we understand that all truth passes through 3 stages. First, it is ridiculed. Secondly, is violently opposed. And third, is accepted as being self-evident.